ahead and just stay in your seats, and I'll pick them up here in just a second. Okay, good morning. I think I do see Oxity. I do see Lawton. So are y'all ready to get started?
Elk City's ready.
All righty. Okay. I hope you enjoyed the quiz. I'm sorry, I did have a typo that I noticed this morning that was a very major typo. I was able to fix it for us. I did have to call Tiffany and Spring and Elk City to fix it, but and we'll talk about that here shortly. But pH is very, very important. 7.35 to 7.45. My typo was I accidentally put 7.25. So 7.25 for a pH. That's not good. That's definitely acidotic, which we'll talk about here later. So, but you would think that just such pH is just a very, very, very tiny window. And our body keeps us normally at that pH of a 7.35 to 7.45. And that's really important that it does that. But we will talk about that later. We are going to go ahead and get started. We're going to be, okay, so in your book, we're going to start in the chapter 16. I believe it's 17 for the old edition. It is the chapter of fluid, electrolyte, and acid base imbalances. And there's so much information in here. It's not enough even really for one lecture period, and we still got to try to cover two completely different chapters, but I think we'll be able to do that. I will be skipping some of the information in the book. It doesn't mean that I'm just skipping it, that it's not important. It is important that you read that as well. It's just that we don't have enough time to cover everything. I am going to go ahead and switch over to a PowerPoint. Now, and this PowerPoint is actually from last year. So it does say chapter 17, but we really are in chapter 16. But again, I know for some of you, that is chapter 17 in the old edition. So let's see here. We're talking about fluids and electrolytes first. This again, chapter 16 in the new book, chapter 17 in the old book. Let me see if I can just slide. Okay, can y'all y'all can see that? Okay. Yeah, there's 115 slides. The slides in this book are can you hear me?
We don't see your.
Oh, I'm sorry. I forgot to push the button. Sorry. Let me see here. How about now? No. Can y'all see that now?
Yes.
Okay, good. I am using this PowerPoint. The PowerPoints are very, very good. They're almost too detailed, but they do make very good study guides. So I would, even if you're not doing it for lecture purposes, I would look at these slides because they're good and detailed. So let's get started. So again, we're going to talking about the normal physiology of the body in relation to fluids, electrolytes, and acid-base imbalances. And again, we come to that word that we talk about a lot. It's probably the first word that you learned in physiology, homeostasis. And we want to maintain body homeostasis. And part of doing that is maintaining all of our fluids and electrolytes in what we consider normal ranges. And that's what we're going to be learning about today. And it isn't just one mechanism in the body. It's so many mechanisms working together to keep that fluid and electrolyte and acid-base balance correctly in the body. What is one of the body systems? Well, I really think of, there's so many. Just off the top of your head, what's the first body system you think of that helps this, keeps us in balance? Respiratory, right. Because we're breathing in oxygen, but we're also, and a very important part is we're breathing off what? CO2. And CO2 is a very, very important factor in our pH balance, right? So what's another body system you think of quickly? I'm sorry? Kidneys, the renal system. Yeah, because that's the body system that does remove our waste products. And of course, it removes our fluids, our excess fluids, but it also helps balance out sodium, potassium, etc. Okay, so what else?
The skin.
The skin, yeah, the skin does. Maybe not as much as other systems, but definitely, but if nothing else, it keeps our water in our body for the most part, except for perspiration. So it's very, very important. Where do our hormones come from? The endocrine system. Endocrine system is so vital in this role as well. It influences the respiratory system. It influences the renal system. Okay, so anyway, so it's very important. So we do need to know, understand how our fluids of the body are composed. What is the level of electrolytes within the body? The electrolytes are going to differ outside the cell and inside the cell when we talk about that here in just a minute. Your level of your sodium is very different outside of the cell versus inside the cell. And when we draw labs, we're doing a serum. If we're drawing electrolytes, we're drawing blood, of course, but what we're measuring is the serum sodium, the serum potassium. So that's what is outside of the cell. It would be very different if we had a tiny little needle and we could poke into the cell and draw out that fluid. Your chemistry panel would be completely different, which we'll talk about in a minute. So anyway, it's very interesting. I love labs. Anyway, and of course, water content does vary with age when we're just talking about water in general. It also varies more with gender, male versus female, and with fat content. Okay. Let's see here. And that just shows you, that's just a good picture of body water over the lifespan. Preterm infants have a percent of body weight that is around 80%. And it basically just decreases with age. So when, oh, that sounds bad. When they say you dry up, I guess you really do. Gosh, but I didn't say that. Please don't. I'm probably one of the oldest ones in here, so I should be offended. I'm offended at myself, but anyway. So, but we do, as far as the percent of body weight that's actually fluid, does decrease over the lifespan. So that's important to know. First of all, it's important to keep everybody hydrated. It's important to remember with our elderly, especially, that they have less water in their body in general. So then when they become dehydrated, it's very serious, very quickly. So again, talking about the different fluid compartments, basically there's two different types. You have intracellular fluid and extracellular fluid, and that is on page 271 if you're kind of following along. So let's look at that real quick. It says the fluid in the extracellular space is the extracellular fluid, ECF, and the two main compartments containing ECF are the interstitial fluid, or the spaces between the cells, and the intravascular fluid, or in the plasma. When I kind of think of interstitial fluid, I'm thinking of kind of tissue fluid, the fluid that's kind of pushed out into the tissue. And of course there is fluid there. And of course then you have your plasma, which is the liquid part of the blood. But again, this is all the fluid that's in between the cells. You do have other compartments as well, including lymph and transcellular fluids. And that includes the fluids in the cerebrospinal fluid, the fluid in the GI tract and the joint spaces, and pleural, peritoneal, intraocular, and pericardial fluid. So again, we don't think about those areas as much, but like within the pericardial space between that in the pericardial sac, which is basically the little sac that goes around the heart. And then of course you have your heart. There's a little bit of fluid within that space. Normally I think it's about 10 to maybe 50 mLs at the most. When you get too much fluid in there, sometimes it's blood because maybe you have some type of injury, after a car wreck, and all of a sudden you have this severe pericardial effusion that leads to cardiac tamponade. Talk about that later, but sometimes it develops slowly. Maybe sometimes when you have congestive heart failure, over time you just collect more and more fluid into that space. That pericardial sac does stretch a little bit, but you can think about if you have too much fluid in that pericardial space and that sac that's around the heart, that's going to put pressure on your heart, and at some point your heart's not going to even be able to move, to contract, and then you're going to basically have a person with no pulse. And that's cardiac tamponade. When you have a patient that has no pulse, you have electrical rhythm maybe going on, but the heart can't, move because of the fluid around the heart. So there's so many different places that fluid is in the body that we have to be concerned about and think about when we're thinking about our patient care. So, but right now we'll kind of, for our discussion, probably focus mainly on the plasma, which is around the blood cells, but in the vascular system, and the interstitial fluid, which is kind of the fluid that's in the tissue. And of course, again, then you have your fluid inside the cell itself. Okay. So that just kind of gives you a picture description of where the fluid is, how much fluid is where. 3 liters in the plasma, 10 liters in our tissue. Intracellular fluids, 28 liters. So really more of our fluids in the cells. Okay, so then in all this fluid, we have electrolytes, and electrolytes are very, very important in maintaining our homeostasis. These are substances whose molecules dissociate into ions when they're placed into water. And so you have 2 types, and this is more chemistry really, right? But cations are positively charged, anions are negatively charged. So just what is the most important, I guess you could say, serum electrolyte in the body, or the one that's the highest amount that we really measure every time we do a BMP, basic metabolic panel? Sodium. Sodium is normally what? So is that inside the cell or outside the cell? Outside the cell. It's extracellular. It's in the serum. Your normal serum sodium is 135 to 145. You need to know that for the rest of your life. That's one that you shouldn't have to go, oh, let me go look at the normal range on the labs. You should know that one forever. So 135 to 145 for sodium. If you were drawing it, it's a cation. Has one extra electron, or I'm sorry, I guess negative electron. Anyway, it's positive. If you write it Na+1, it's a positive cation. It's a cation. And that's in your book there. It shows that. So what is the most important cation as far as inside the cell? It's also important outside the cell as well, but it has the highest concentration inside the cell. Potassium, right. Potassium, of course, is K, okay? Not vitamin K, don't get that confused, but just the K. And it's also a +1 cation. And there's a good table if you look there. I'm probably jumping ahead, but let's look at 272. It's figure 16-3. I might even have it here. Let me see if I have it here. Yeah, there it is. So this shows you your sodium and your potassium, calcium, magnesium. Those are probably the most important electrolytes, along with chloride. That's chlorides are probably the main anion that we kind of talk about. We don't talk about chloride a whole lot. It's like if your sodium is high, then your chloride usually is high. If your sodium is low, your chloride is low. We focus more on the sodium when we're looking at serum electrolytes. But this just shows you, this is what we're looking at on the plasma side when we're drawing, again, that serum electrolytes. We have a lot of sodium, but we don't have much potassium. What's a normal potassium level when we draw it? 3.5 to 5, okay? And that's, again, a very kind of narrow window, a very important window. You also have calcium and magnesium, are other important ions, cations that are in the blood as well, in the serum. Now look at the comparison to inside the cell. Your major cation inside the cell, the one that you have where your concentration is, it's potassium, okay? I think it says in your book, if you were actually able to measure inside the cell, I don't know if it says it or not, but anyway, your potassium level inside the cell is 100 and something, okay? Just like on the outside of the cell, sodium was 135 to 145. And this is just a side note here, but this is why sometimes crushing injuries or crushing type injuries elevate potassium. Because think about it, if all of a sudden you have all your potassium mainly inside the cell, and now all of a sudden a piano falls on our legs. I don't know why I would say that. I think it's the kind of commercial I've seen. But anyway, if you can just imagine all of a sudden you're sitting down and a big piano falls on your legs. So you have this huge crushing injury to all your muscles. And those cells are squished. Those cells are going to break. And what's going to be released? Potassium. So that's a lot of times why you have high levels of potassium with any type of cellular destruction. So any type of severe injury, big injury. Sometimes you have patients who, they're little older ladies or gentlemen, they fall down at home, they're not able to get up. They're trying to get up sometimes for 6 to 8 to 12 hours. They're lying on that hard floor. Guess what? That's also similar to that crushing injury. So when they come in, sometimes they end up in a thing that we call, which we'll talk about later, but rhabdomyolysis, because of the muscle destruction that the body has undergone. But one of the things that you do look at there is electrolytes, potassium, and a lot of times those potassium levels are elevated because of that. So that's just one little way that sometimes potassium can become elevated in those type of injuries. But just important to remember overall that outside the cell, in the serum, we look at sodium and potassium especially. Those two numbers you do need to always know. So sodium 135 to 145, potassium 3.5 to 5. Calcium and magnesium, it's in your book, and we'll talk more about that as we get there. Okay? And again, just making sure you understand that outside the cell is so much different than inside the cell and our balance of electrolytes. That leads us into talking about, so we talked about that. Do know that intracellularly, the prevalent cation is potassium. We just said that. Your prevalent ion is phosphate. PO4, I believe, is phosphate. And then your outside the cell, this is what we measure. The prevalent cation is sodium, and the prevalent anion is chloride. Make sure you know that. Okay, we've talked about that already. So now we're going to talk briefly, and I'm going to really talk briefly here. You need to get a good understanding of it by reading your book. But more, we're going to then be applying these principles to our disease processes as we continue this discussion. But you need to understand, to a degree, diffusion. Diffusion is really pretty easy. It just simply means it's the movement of particles across a semi-permeable membrane in order to achieve balance on both sides. Okay, so some processes in our body work upon this principle of diffusion. Again, that's simple, and there's a picture in your book. If we put a lump of sugar in water, and you did this in science, probably what, 3rd, 4th, 5th grade. You put the lump of sugar in water, and then over time, you don't even really have to stir it necessarily, although stirring just helps it hurry, make it faster. Over time, those particles are going to move about in the water. Actually, I should have mentioned the semi-permeable membrane is talking about osmosis. I shouldn't have mentioned that yet. Anyway, but just over time, the sugar molecules break up, kind of go into the water, and are balanced then in all parts of the water. That's simple diffusion. Some other things in our body do work on that same principle called facilitated diffusion. And that is there on page 272 in your book. It says facilitated diffusion involves the use of a protein carrier in the cell membrane. The protein carrier combines with a molecule, especially one too large to pass easily through the cell membrane, and it will assist in moving the molecule across the membrane from an area of high to low concentration. Like simple diffusion, facilitated diffusion is passive. It requires no energy. An example of diffusion is our glucose transport into the cell. The large glucose molecule must combine with a carrier molecule to be able to cross the cell membrane and enter into most cells. So what is that molecule? It should be insulin, right? We know that we have to have insulin in our bodies. Of course, in the normal body, it's made by the pancreas. That insulin, which is comes from the pancreas, the isolates of Langerhans, right? The beta cells of the isolates of Langerhans. Anyway, that it basically helps just carry the sugar into the cell. So you have sugar all over the body because we just ate a big meal. We ate a wedding cake because I'm about to have, my daughter's getting married and we're paying a whole lot of money for that wedding cake. So I'm going to have a big piece of that cake. So, and I haven't been eating any really carbs up until, I'm not going to eat carbs until the 27th, but I am going to make up for it on that day. But anyway, so I'm going to have all that sugar floating around in my body. My pancreas is going to be surprised because it hasn't seen that in a long time. And it's going to make all this insulin, and that insulin helps. It just basically takes the hand of the sugar and pulls it into the cell. And then when you're diabetic and you don't have insulin, that's what the problem is. You don't have insulin helping sugar get inside the cell. So inside your cell, everything thinks, oh my goodness, I'm starving. And you eat more when you have that, especially type 1 diabetes, because you think you're starving because that sugar is staying outside of the cells, not inside. So that process of using insulin to get sugar inside the cells is facilitated diffusion. Very much like diffusion, except we're just having to use that hormone, that insulin, to help get the sugar inside the cell. Then you have another thing that's similar, and that doesn't require energy, it just requires the hormone insulin. Then you have active transport. Okay, this is the process in which molecules move against a concentration gradient. The example here is our sodium potassium pump. And that is very, very important in the contraction of what cells?
Is it muscle?
Muscle, specifically cardiac muscle especially. Okay, that's why it's, we'll talk about it in a minute, but that's why the balance of potassium especially is so important. And when we don't have our potassium correct in our body of 3.5 to 5, we always worry about the heart. Always worry about the heart. Too much potassium is bad on the heart, and too little potassium is bad on the heart. And it stems back to this process right here, active transport. So let's read that real quickly. Active transport is a process in which molecules move against the concentration gradient. External energy is required for this process. An example is the sodium-potassium pump. The concentrations of sodium and potassium differ greatly inside the cell versus outside the cell. To maintain this concentration difference, the cells use active transport to move sodium outside of the cell and potassium into the cell. The energy source for this movement is adenosine triphosphate, which is made in the cell's mitochondria. And I think y'all remember talking about ATP back in high school. I remember I had a really good discussion. At the time I understood it. It's kind of left me now. It's been that many years. But I just remember that we get energy from ATP, adenosine triphosphate. The process of it going to adenosine diphosphate releases that energy molecule. And we have to use that energy in this process specifically. Now just keep that in mind, that it's so important to have energy for active transport, and that we're working basically almost against diffusion, our principles of diffusion here, but by using active transport and then you can refer to that picture there that's in your book and also up on the screen. In order to get heart muscle to contract, you have to have that movement of potassium into the cell and sodium out of the cell. In normal diffusion, it wouldn't want to, okay, because there's a whole lot of potassium already in the cell. So you have to use active transport to get that potassium into the cell. Again, though, that's why that balance outside of the cell is so important, which we'll talk a little bit more about in a minute. Okay? So these are just different ways that fluids and electrolytes are moving in our body. We have simple diffusion. We have facilitated diffusion. We have active transport. Now we're going to talk a little bit about osmosis. Osmosis is important to kind of understand, especially when you're thinking about what type of IV fluids are hanging for my patient. Is it an isotonic solution of sodium chloride 0.9%? Did I say that right? Yeah, 0.9%. Yeah, okay. Is it a hypotonic solution of sodium chloride 0.45%, also known as half normal saline? Is it some type of hypertonic solution? Okay. So you kind of need to understand osmosis for that reason. So this is just movement of water against concentration gradients. So this is where you do now have sort of like a semi-permeable membrane. And your cells sometimes act as that semi-permeable membrane for certain types of things in the blood. So one of them is protein. Okay, so here we have a net osmosis. So on one side we have albumin at 5% concentration. On the other side we have albumin at 10%. Now albumin can't cross this membrane, okay, but water can. So water is going to flow from the 5% side, right, to the 10% side to lessen the concentration over on the other side. And that is the principle of osmosis. And we see that kind of have a play as our blood moves through our body. And then at that capillary level, because it's at the capillary level, right, where we have that exchange of fluid and electrolytes and nutrients. So we're carrying all this good stuff in our blood. We're carrying oxygen in our blood. We're carrying proteins in our blood, food, or nutrients, I should say, nutrients that have been broken down by the digestive tract. Once it finally gets over into the capillary area, that's where then it actually then gets pushed into the tissue area. And that's where then we actually give our tissue oxygen, where we give our tissue nutrients, where we give our tissue fluids. And then we're taking back the waste products from the tissue. We're taking back the CO2 from the tissue, okay? And we have to keep this fluid moving through the body. And so there's different types of pressures that have a play in that, okay? So this osmosis, just this principle of osmosis, is sort of important to remember as we enter now the discussion of our hydrostatic pressure and our oncotic pressure, okay? So osmotic pressure is the amount of pressure required to stop osmotic flow of water, determined by the concentration of solutes in a solution and your fluid tonicity. So again, when we're talking about IV fluids, I know this gets really confusing, but think of terms of isotonic, hypotonic, and hypertonic, and what happens to your blood cells in those different solutions. Isotonic, as long as your electrolytes are normal, and as long as you're not really dehydrated or overhydrated, but you still maybe need some IV fluids, probably you're going to be given some type of fluid that is isotonic in nature, okay? So where are we in the book? Let's see. It talks about fluids. Yeah, we'll talk more about fluids, I think, here in a little bit. But just you're probably your most standard isotonic solution would be sodium chloride, 0.9%, also known as normal saline, okay? You have to be careful when you're thinking about especially red blood cells and the effect of water status on red blood cells. Actually, I'm not thinking as much about IV fluids right now as I'm thinking about the balance, especially of sodium. Because sodium is our biggest cation, bless you. It's our biggest cation in the extracellular fluid. So remember, our cells are in our serum, okay? So when we have a normal balance, when our sodium is that nice normal 135 to 145, our red blood cells are just fine, okay? But if we end up getting, and we'll talk about this in a minute, if we get low levels of sodium, then it's like our red blood cells then are kind of in a state of being in a hypotonic solution, because normally if my sodium now is, I know my sodium level should be 135 to 145, but what if for some reason our sodium level drops to 120? Then because of the principle of osmosis, it's going to pull water into the cell, causing swelling of the cells. This is just the example with red blood cells. And then what if the opposite is true? What if the sodium now for some reason is really, really high? What if our sodium normally is 135 to 145? So what if our sodium level is now 150? Our cells will kind of shrink, okay? So that is kind of that principle there. So that's one way that electrolytes will affect movement of fluid inside and outside of the cell. Another is hydrostatic pressure. This is blood pressure generated by the heart contraction. And if you look in your book there on the bottom of page 273, it explains it as this. Hydrostatic pressure is the force of fluid in a compartment pushing against a cell membrane or vessel wall. In the blood vessels, hydrostatic pressure is the blood pressure generated by the contraction of the heart. This hydrostatic pressure in the vascular system gradually decreases as the blood moves across the arteries until it is about 30 millimeters of mercury in the capillary bed. So our blood pressure starts as we're leaving the aorta, right? Our blood pressure is 120 over 80. Now that blood, and that's pretty high, 120, systolic at 120. As the blood moves through our body, from the aorta into the smaller arteries, slowly that pressure is decreasing. Where you get down to the capillary bed, your pressure has now dropped to about 30 millimeters of mercury, from 120 down to 30. That's okay. That's where it's supposed to be. It's at the capillary level. Now the 30 millimeters of mercury, that's still enough pressure. It now pushes some of that fluid into the tissue so that we can now have the oxygenation of the tissue, the nutrition of the tissue, and then also the removal. Well, actually, that's what we're doing first. We're pushing that out into the tissue with that hydrostatic pressure of 30 millimeters of mercury. Okay? Now the question is, as we're traveling to the end of the capillary, now we're getting into the venous system, right? How now is that extra fluid that we just pushed in the tissue, how is it getting back into the capillaries? Okay? That's where oncotic pressure comes into play. So let's read about oncotic pressure. We'll watch that in a minute. Okay. Oncotic pressure in your book says this. It is the osmotic pressure caused by plasma colloids in solution. The major colloids in the vascular system contributing to osmotic pressure are proteins such as albumin. And I don't know if the older edition says that, because I was kind of looking last night and I have my older edition at home and I couldn't find albumin. So I do need you to know that one of your major proteins in the body is albumin, and especially that albumin is important for this creation of the oncotic pressure. It's an important protein in your vascular system. Okay, so our blood has traveled from our heart through the aorta at a pressure of 120. It's kind of gone through our arterioles, our arteries, down into our arterioles, and now it's at the capillary bed at a pressure of 30. Now we have pushed this fluid into the tissue. We have given our tissue oxygen. We've given our tissue nutrition and water. But now we need to pick up on the other side of that capillary as we're going into the venous system. We need to pick up the waste products, the extra fluid, and the CO2. We do that by oncotic pressure. So this albumin and these proteins that are in the blood are creating like a negative pressure, and it's pulling the fluids back. And it does that. It says that under normal conditions, plasma oncotic pressure is about 25 millimeters of mercury. The small amount of protein found in the interstitial space exerts an oncotic pressure of about 1. So there's a little bit of protein in the interstitial space, but it's not much. The majority of your albumin, your protein, is in the vascular system where it should be. So then what happens if all of a sudden, for some reason, or maybe over a period of time, our oncotic pressure is really low? And one of your major reasons for that would be low levels of albumin. So when do you see low levels of albumin? The elderly, because they're not eating as well. What about patients who have cancer, who have maybe end-stage type cancer? Again, they're not getting good nutrition because their body's not allowing them to because of the cancer, the process of that. A lot of times you see severe swelling in your patients with cancer because of, again, this low oncotic pressure. Sometimes when in liver disease, again, because of the different things that are going on with liver disease, you have low levels of albumin in the blood. Thus, you have a decrease in oncotic pressure, so you're not able to get that fluid out of the tissue as well as in the normal person with the normal levels of albumin. So people who are severely malnourished, people who do not have good levels of protein, your different disease processes would include anybody like cancer patients, patients maybe with end-stage AIDS. Those are just a few examples, okay? So with that being said, sometimes, and it's very difficult, you think you would say, well, just give them albumin. And we can do that. It doesn't work. It doesn't stay in the vascular system very long when there's an underlying disease process. It's really better to fix that underlying disease process. But that's why we don't talk about it a whole lot, but oncotic pressure is so important. It pulls the fluid from the tissue back into the capillary bed, and then it travels its way on back through in the venous system back to the heart. And if you don't have good oncotic pressure, you're not going to have that. So if you had a patient maybe who does have maybe poor nutrition, what is an assessment finding that you might expect to see because of what we just talked about? Edema. So did just somebody say edema, huh? Yeah, that's probably one of the important things you're going to see assessment-wise. It could be all over the body. I still remember this one patient I had. I believe it was liver cancer. The patient had end-stage liver cancer, And she had and I think it's called anasarca. We'll talk about it more later, but it was an overall body edema, and it was it's hard to explain. Normally, kind of edema is sort of, makes your tissue kind of fluffy. I'm not really fluffy, but squishy, I guess is a better word. Anyway, I was helping this little lady up to the bedside commode, and there was actually two of us. She was really weak. I was behind her, and I had my hands on her back, just kind of holding her up in bed until the nursing assistant could get over there and kind of help her stand. So I probably had my hands there for maybe 30 seconds, maybe a minute at the most. And she was leaning back against me some, but when she stood up, my handprints were in her back completely. Like you could see my entire hand on both sides of her back, because she had that much what we call brawny edema. That's another term I've used. It's what I consider hard edema. Y'all can and I think another term is anasarc. I can't remember the spelling, but anyway, she had very low albumin levels because of the state that she was in due to the end-stage liver cancer. And so that was what I saw as a result of that edema. So if you have a patient, and for whatever reason, maybe we are able to correct that nutritional problem, and we are seeing improvements in the albumin level, what would you expect them to see assessment-wise? Yeah, a decrease in that edema, right? So just kind of a note there. That's just one way that we can just kind of, in a way, monitor the albumin level indirectly, I guess you could say. So it's really important. You're not going to necessarily see a whole lot of questions geared toward this, but you need to understand these principles in order to then talk about the disease processes that we'll talk about here in just a minute. Okay. And like I said, so hydrostatic pressure is created by our blood pressure. Basically, that's that pressure that gets the fluid out into our tissue at the capillary level. And then it's the oncotic pressure that pulls the fluid and the waste products back into the blood, into the vascular system. Okay. And that's just another picture, basically, of it, right? So here we have the arterial end. Here's our pressure at around 30 to 40 mLs of mercury, hydrostatic pressure, basically coming from the heart. That's pushing then at the capillary level fluid and nutrients into our tissue. Then, now we got to get this fluid back, because now the blood's kind of flowing through the capillary bed. And now we have this oncotic pressure of 25. The hydrostatic pressure here is only 10. So that's pulling, but that allows then, because of the kind of this osmosis principle and pressure principle, it pulls the fluid back into the vascular system, and it goes on its way back to the heart. Okay. So we know that plasma to interstitial fluid shift results in edema. Interstitial fluid to plasma decreases edema. We just explained that, right? We all understand that. We need to have that balance. First, spacing. Let's talk a little bit about spacing. So we're talking about fluid shifts. We're on page 274. Fluid spacing is a term used to describe the distribution of body water. First spacing describes the normal distribution of fluid in the intracellular fluid and the extracellular compartments. So that's normal. First spacing is normal. Second spacing refers to the abnormal accumulation of interstitial fluid, and then third, which is edema. And then third spacing occurs when excess fluid collects in the non-functional area between the cells. The fluid is trapped where it is difficult or impossible for it to move back into the cells or the blood vessels. Third spacing occurs with ascites, fluid leaking into the abdominal cavity with peritonitis or pancreatitis, and edema associated with trauma, burns, or sepsis. So just simple edema is really second spacing, not third spacing. I think I've heard that term, honestly, maybe used a little bit incorrectly during my nursing career. Okay. Third spacing is where it's really pushed out into an area where it's very difficult to get it back. Again, just as your book mentions, with peritonitis, pancreatitis, ascites from liver disease. We'll talk more about burns actually next semester, but you lose so much fluid when you have a severely burned patient. Okay, so just kind of keep that in mind. Sepsis, I know that we're really having, I think, more discussion about sepsis in hospital settings where there's a big focus now on sepsis, where there wasn't several years ago. And again, with sepsis, you can have that third spacing. So, okay, but just kind of keep that in mind, okay? So then, well, how do we regulate the water balance? This is what we kind of talked about just briefly at the beginning. What are the different body systems that help us regulate that? Well, definitely at the very beginning, when you think of endocrine system, you kind of first start thinking about the hypothalamus and the pituitary gland. So it definitely has a role. You have these receptors in your hypothalamus. They actually sense fluid deficit or increase in fluids, okay? And because of that, those receptors, if they're stimulated or not stimulated, they will either, they will stimulate thirst, and they will stimulate the antidiuretic hormone release, okay? And a decrease in plasma osmolarity, water excess, suppresses antidiuretic hormone, okay? So when you always have to think about this, ADH, where does it come from? It comes from the, is it the anterior or the posterior pituitary? Anybody know? Y'all should know. I should know right now. I'm pretty sure it's about posterior pituitary, right? Well, yeah, well, oxytocin and ADH come from the posterior. You don't have to know that again necessarily. Just sometimes I like to get that in my head, but antidiuretic hormone is against diuresis. Okay, so if you have a lot of ADH, then you're not going to be diuresing, right? Because it's against diuresis, right? Okay, so I always have to think about that. So if you, as it says here, if you have a deficit in water, then your body is going to become thirsty, right? But that's just natural because if we are dehydrated, we're going to be thirsty, and we're going to release ADH because we're going to try to then hold on to our water, not let it go through the kidneys. So if we're running a marathon, okay? And oh boy, we're getting really thirsty. We're gonna try to drink water, but we're still dehydrated because we're losing a lot of water because we're sweating a bunch. Our posterior pituitary is gonna be making ADH, making it so that we hold on to the water that we do have. So we're not gonna have to really find a bathroom when we're running a marathon because we have ADH, right? And we're kind of trying to hold on to our body. But then when we have too much water, we're going to suppress the secretion of ADH against diuresis. And so now our urine output should increase. That's just basically how that works. Okay. Let's see here. And so what about water balance at the renal level? Okay. Basically, primary organs, of course, for regulating fluid and electrolyte balance are the kidneys. It's not just necessarily getting rid of extra urine, or fluid through the urine. We're doing a lot of different things within that nephron of the kidney. Remember, the nephron is the functioning unit of the kidney. And what are all the different parts of the nephron? You have your glomerulus, and then you have your proximal convoluted tubule, distal convoluted tubule, and so many electrolytes are going back and forth in those areas. And you have your loop of Henle, right? And again, same thing. So many different things going on in those areas. And a lot of your hormones influence how that nephron is balancing our sodium and other electrolytes. Okay. So we're not going to go into that detail. We'll go into that detail probably when we get closer to actually talking about the kidneys, but just understand that it's very important. Our adrenal cortical regulation is also important in water balance. You have glucocorticoids released by the adrenal cortex. You have your mineralocorticoids. Your main one there is aldosterone. That's definitely has a major role in our fluid balance. In fact, one of your spirulactone, I think it's a drug that you can give, sometimes kind of like a diuretic, but it has its effect in that area. So I'm not going to go too much into this, just make sure you kind of understand that in general that it does, there's so many body systems that do balance it. Even cardiac regulation, you have natriuretic peptides are antagonists to the renal angiotensin system. I think that this is getting into too much detail, so I'm going to go ahead and skip over this. Although I'm going to mention this real quick, and I'll mention it again when we talk about cardiac. Let's focus on the heart real quick. We're going into talking about congestive heart failure. Congestive heart failure, of course, we kind of know is when there's too much fluid in the body. Basically, that is because the heart muscle is weak. It's not mobilizing those fluids as well as it normally does. And so we end up getting edema a lot of times. But there's this extra volume within the vascular system. So the heart senses that because basically there's also baroreceptors within the heart. Those sense pressure. So it's sensing this extra pressure created by the extra fluid. And it releases a hormone that I think sometimes we refer to as BNP, brain natriuretic peptide. And just look at the word natriuretic peptide. Uretic, you're thinking of diuresis. So BNP is actually a natural hormone released by the heart when especially the atria stretches. And then that actually goes and it affects the kidneys and it causes a mild diuresis. How do we use it as healthcare workers? We use it as a marker to measure, is our patient in CHF or not? Okay, so a lot of times when a patient comes into ER, they do seem like they are having lots of problems breathing. And maybe we're not even exactly sure initially, is it COPD type problems or is it congestive heart failure type problems? One way is simply to draw a BNP, brain natriuretic peptide. If that marker is elevated, then that is definitely saying probably your patient is in congestive heart failure. Now, I can't remember the exact numbers. I want to say 0 to 1800 is kind of the normal level. It partly is in part based upon the person's age, but I think for a patient that's older than like 70, normal is 0 to 1800. If it's over 1800, then that means that probably the patient's in CHF. And the number varies greatly because I've seen patients who've had as high as 70,000 for their BNP, and they were in severe heart failure. So it can really get really high. But anyway, just again, there's so many different factors that regulate water, okay? We know definitely the GI system, okay? Of course, we're drinking water through the GI system. Oral intake accounts for most of our water intake. Small amounts of water are eliminated by the GI tract and feces. So two different disease processes or problems that can be going on, diarrhea and vomiting. That would definitely, you can see why that would be significant in a fluid and electrolyte loss. So just kind of keep that in mind. And we are losing a little bit of water in ways that we can't really measure. That's what we call insensible water loss. It's difficult to measure, but we are, as we're breathing and talking, we have that vaporization of water from the lungs. Also, we have some that's leaving the skin. And this accounts for approximately 600 to 900 milliliters a day. And there's really no electrolyte loss through here, but there is water loss. Okay, so it's not going to be perfectly matched on you at the end of the day. If your intake, if you're measuring I's and O's and they drink 1,200 mLs of fluid, then in 24 hours, it's not necessarily going to be that they must have urine in the amount of 1,200 mLs per day. Now, we don't really, when we're monitoring I's and O's, keep exactly track of insensible water loss because we can't. But it does need to be we need to be mindful of that when we're figuring our I's and O's. Okay. I'm going to skip through some of this because we have to. Remember, for the elderly, I never can say that word, gerontology considerations. Remember, first of all, that they do have a reduced thirst mechanism. And so they just don't know they're thirsty. They don't think they don't have a sensation of thirst, even when they're dehydrated. So we need to be advocates for our patients, especially in the elderly, to really, unless there's a fluid restriction ordered, which there might be, which I'll talk about shortly, but unless there's a fluid restriction ordered, we need to be giving them fluids, encouraging fluids. I posted this on my Facebook, not that really you're on my Facebook, but somebody invented this. It was a younger guy, and he did it for his grandmother, but it was, what was it? It was like jelly. jellies, like, you know, the little gummy bears that you eat, and they're so good. I love gummy bears. But anyway, these were like big gummy bears, and they were fruit flavored, and they were full, not full of, but had a lot of juice in them. And so he made that for his grandmother, and actually invented this to increase her fluid intake. So I thought that was really interesting. But nursing homes, especially if you're in a situation where especially you're caring for people who are elderly, or maybe you have a large population, keep that in mind. You need to always be mindful of ways that we can increase their ability to drink, or encourage their intake of fluid. I know in the hospital setting, I get frustrated sometimes, and that's one thing I actually do. Anytime I leave the room of an elderly person, I usually say, hey, can I help you get a sip of water? And often they say, yeah, that's fine. And because a lot of times the cups that we provide for them in the hospital setting are those huge cups, and they're really weak. They're in the hospital, obviously, because they're sick. Usually that means that they're also very weak, and it's very difficult for them to pick up those big cups. So really be mindful of your patient. Are they able to pick up the fluid container that I just gave them? Or do I need to somehow alter the fluid container I just gave them? Do I need to make it a little bit smaller? Do I need to go in every hour when I'm making my nursing rounds? Because we're doing nursing rounds, I know, in our hospital setting in Jackson County, and this is probably true for all the other facilities. Somebody should be going in there every hour, whether it's the nurse or the nursing assistant. And really, they should be offering them at least just a sip of water, if nothing else, every time they're there. Okay? So anyway, just keep that in mind. There are definitely some reasons as you age that it's difficult to get more fluids in. A lot of times they also, maybe they do have CHF, and they know that they take a diuretic. That diuretic does make them go to the bathroom quite a bit. They're about to go shopping for the day. They maybe have a little bit of underlying also some incontinence, maybe some stress incontinence. And they don't want to take their Lasix because even though they know it's better for their heart, they don't want to because they're about to go, out shopping for the day, and they don't want to have to go to the bathroom or have a possible case of incontinence. So I've also seen that where patients end up in trouble. It's actually kind of on the opposite side there, but they're not taking their medications like they should because they're trying to avoid the side effects of the medications, as in Lasix, diuresis, mixed with stress incontinence can lead to a bad situation sometimes out in public. So again, just things you need to think about when you're taking care of your patients. Definitely fluid and electrolyte imbalances can be there or can exist directly by cause of a certain disease, or indirectly because of other diseases. Burns, again, you lose lots and lots of fluids when you have a burn patient. Heart failure, sometimes you have a problem with getting rid of the excess amount of water. So you do have to put patients on fluid restrictions because of that. And it can be the results of how we're giving them either fluid replacement and or diuretics that will change the balance and cause imbalances. We know with Lasix, what do you have to watch for electrolyte-wise? You always need to know your potassium level, because we know that Lasix works on we call it a loop diuretic. It works on the part of the loop of Henle where we lose potassium. So sometimes when we give and I heard a doctor say this, the more sodium we eat, so if we're a person who likes to eat lots of chips and high sodium amounts of food, and then we take a Lasix, our potassium level is going to drop more quickly than maybe in somebody who doesn't eat a lot of high sodium foods. Okay, so kind of just keep that in mind. But we do need to always be aware with Lasix, for instance, what is our potassium level? If we need to, you should know that and be able to tell your clinical instructor that in clinicals. It may not be that day, but hopefully it's within the last few days. And also, especially if you are giving a potassium type replacement medication, which, as you know, often our patients are on, because they are losing extra potassium because of the Lasix, because it's affecting the loop of Henle, and we are losing extra potassium that way. So we need to give a potassium replacement. There's other drugs out there as well that affect that, which we'll talk more as we get into those areas. Okay. So now we're talking about just in general, where are we in our book? But hypovolemia and hypervolemia. So hypovolemia just meaning that we overall do not have enough fluid in our blood. So different diagnoses that could pertain to that would definitely be deficient fluid volume. Okay. And I think we're kind of on page 276. It would be decreasing cardiac output, possibly, because if we don't have enough fluid in our blood, in our body, then probably we don't have enough fluid in our vascular system. So then our heart's not going to be able to pump out as much blood because simply the volume isn't there. So what would be one of your signs or a few of your signs that you have decreased cardiac output? Weak, ready pulse. You see that, if nothing else, when you hypovolemic, maybe shock, maybe you have blood loss related to some type of injury or maybe a surgery. Okay, so and that would be, weak, ready pulses. Flattened veins, maybe you definitely probably wouldn't have JVD, right? Blood pressure, you probably have a lower than normal blood pressure. Okay. What about risk for deficient fluid volume? What might be a couple of things that could be going on with our patient that might put them at risk for deficient fluid volume? Yeah, nausea, vomiting, diarrhea, just right off the top of the head. Very good. Potential complications, hypovolemic shock. So if maybe we are having a patient, maybe it's a gunshot wound, and now they're bleeding out. We're trying to give them fluid, we're trying to give them blood even, but they're bleeding out very quickly. They could very possibly go into shock if we're not able to stop the bleeding and replace the blood and fluids that were lost because of that wound, okay? Now the opposite side of that, hypervolemia, this is when you have too much fluid, okay? So excess fluid volume could be a nursing diagnosis. Impaired gas exchange, that could possibly be related to if you have extra fluid in the vascular system, if some of that, and if you're going into congestive heart failure and some of that fluid is being pushed over into the pulmonary vasculature and into the lungs themselves, you could end up with pulmonary edema. That could be one way that you might have impaired gas exchange. A risk for impaired skin integrity, that could be because of what the edema may be caused by the hypervolemia. Activity intolerance, if there's, again, extra fluid on board, if you're not able to oxygenate as well because of the extra fluid on board, you could have activity intolerance, okay? Disturbed body image, if maybe you have just lots of extra edema, that could, be an issue. So pulmonary edema and ascites could be complications of hypervolemia. So those are just very kind of broad ways that we can then more focus on how is it really affecting our body, how it is affecting our nursing care, what problems are we looking for in our patients who have hypervolemia or hypovolemia. Okay, so what are some different things? And I think we'll stop here. This will be a good place to stop and take a break. We're going into our nursing kind of interventions now. So it is, what time is it? 10:09, so we'll come back at 10:19. No, because I didn't get that message till last night.
Oh, okay.
So you're not. Wait.
Whenever I log in, it just says that my subscription has expired. And one of the girls said that they thought that we'd been given a card. I couldn't remember if it was for that or the passport. I'll ask Melissa because I think
She's not here today.
not here.
No, but
Okay.
Mrs. Jarrett or Ms. Machado should be able to answer that.
If it's gonna happen to anybody, it's gonna happen to me, dear.
I just can't figure why you would have a problem. Because I mean, you came in.
Last semester. I don't know unless they just gave me like a 1 year since I was an LPN and I did the extra semester.
Where did you? Because you came in December. So you haven't even had it for an entire year yet, right? December would be a year, or January would be a year. Wait, did you? Did we use it in the summer program? When you were in the summer program?
I think we did. So maybe it would have expired.
Yeah.
Because it started in June, I think. Okay.
That's the problem. Okay. Let me.
Okay.
Especially it's not even winter yet.
Oh my nose.
Did you?
I know. She died in like 2000. I don't see why it's not a good idea, but I'm very convincing myself. I know, right? So that's why I'm like, maybe let's put an hour. Because I can do it. Not a kid. Yeah, I'm talking like maybe around every year. Not a kid, right? We're going up there. That's amazing. No, I want somebody that just comes to me on that. I know. I mean, I'm trying to go warm up for me eventually. Except for Saturday. No, just yes. I don't know. Yeah. I know. Yeah. It's like, that's what I thought. I don't think it's. We don't really have to. We just sign up. I think it's like if we do it, she would say, like really the only thing it adds is I don't like putting. We have two options. And it's so busy because we have our media for their plan. I mean, like, I've just looked at the. They don't want to do that. Like I took off Saturday, so you know, we're working tomorrow, Friday, or tomorrow is Friday. Tomorrow. You'll get better at it. Yeah. I know, just like I need to try to traumatize me because things happen. Okay. She goes to Upper Vale. She has to make at least 13 to be able to take college classes. She made it 13 on the last one. I told her I'm not paying for it unless she's studying for it. It's going to pay for it and she can't pay anything around it. And I don't, it costs me like $35 or $40. Yeah.
Okay, so.
That's what I just told her. She said she has a back end.
Yeah. You probably bought it for 1 year to go back.
Okay.
Then you bought it in summer.
So we'll need it back. And she just brought hers.
You had to buy it. No. They give you a discount or anything?
Like, what if they?
And they're not, I think we're not doing it. I know that when I online substitute items, because it's a new thing, they purchase for them for 1 year. Something like that.
Okay.
I just wasn't sure. They told us, I said, I remember buying one. Yeah, other one they gave us like a party. Yeah, it was much cheaper, so I'll just run over there later.
The day we get back, or the day we before we go?
Well, that's
Like,
so reduce that infection diagnosis, fluid volume related to is it the actual acid exchange versus what else is before you actually diagnose? Is there something about the actual breathing? This the I think I would choose that instead of the acid exchange. It's more of a mechanical thing. They saw these pushing on the diaphragm.
They changed it.
You're talking about medical.
Yeah, you're
Okay, that sounds okay. I think it's okay. Yeah. As long as you're communicating with her, you know, as well. Yeah. Okay, I think it's at time. Okay. Oh, we're past time. Let's go ahead and get started. Okay. I forgot to mute us. I'm sorry. Can y'all? I hope we didn't say anything bad. Can y'all hear us in Elk City?
We can hear you loud.
Okay, Elk City, can y'all wave if you? We're good. Okay. Okay. Let me get a drink. Let me get a drink real quick. I'm thirsty. Okay. So now we're getting into the things that you really, really do need to have a good understanding of. What we were talking about before, you do need to understand the principles behind it. You need to understand the principles behind what is driving your patient to be, and maybe the imbalance that they're in. But now we really need to get a good understanding of how to care for our patient. So if we have whether we have extra volume, fluid excess, or we have fluid deficit, hypovolemia, we need to be doing different interventions, similar, interventions. We always, first of all, want to be monitoring I&O, intake and output. And I know y'all do this in the clinical setting. You need to be really monitoring, of course, especially if there is a problem. They probably are going to be on strict I&O, right? Where we're truly measuring basically to the milliliter of what we're giving them by mouth, what we're giving them through the IV. And then, of course, their output. We need to be measuring output. So what are some different types of output that patients can have? Definitely, the urine's your main one. So bless you. So urine output. What else? So vomit. If they're vomiting, how much are they vomiting? Okay. What else? Any type of drain tubes, right? Maybe there's some type of surgical drain tube. So we would need to be monitoring the amounts of that. Sometimes there's a fluid that is lost in feces, especially extra fluid when the patient's maybe experiencing diarrhea. So sometimes you can measure the actual liquid you measure the stool if it's very, very liquid in nature. Now, there are times when it is difficult to measure certain outputs. Sometimes it's difficult for the patient to be compliant with that. Maybe they just forget that they need to use the urinal, or they forget that they need to put the hat, make sure that it's in the commode, the urine hat, to catch the urine. And so maybe we end up not getting a good, measurement of the INO. We need to do our very best, of course, as nurses to do that. What is another way that you can kind of measure their fluid status? Daily weights, very good. So that we always tell our patients with heart failure that, because it's so important to catch even the slightest weight gains. And when we're talking about weight gain, we're not talking about, am I getting fat because I ate the extra hamburger last night? We're talking about, am I retaining fluid? And that's what you're going to see in the daily weights. If you have a weight gain from one day to the next, it's very possible that is fluid related, not fat related. Okay. So with that being said, I know y'all know that, but so 1 liter is the same as 1 kilogram of fluid, right? So if your patient weighs 100 kilos one day, and the very next day they weigh 102 kilos, then very possibly they have an extra 2 liters of fluid on board. Does that make sense? Y'all know that, right? So now when we are telling our congestive heart failure patients, we normally tell them if they gain, and most people do weight gains, not in kilos, but in pounds, right? So if they gain more than 2 to 3 pounds per day, or if they gain more than 4 to 5 pounds over, say, a week's time, then those patients need to let the doctor know, because they are retaining too much fluid, and the doctor may need to start them or increase their diuretic. Or maybe they do need to go ahead and come in and see the doctor. Because we don't want them to all of a sudden have a history of heart failure, and then they have to call their home health nurse at 3 o'clock in the morning because, oh my gosh, I can't breathe, and I'm coughing up this pink frothy stuff, and oh my goodness, I feel like I'm going to die. They're in full-blown pulmonary edema, correct? And maybe we could have prevented that if we caught the weight gain of that 5 or 6 pounds in 2 days before they went into full-blown pulmonary edema related to the congestive heart failure. So daily weights are so important for your patients in heart failure. For your patients who are, for whatever reason, they should be on an INO, but we're just having a hard time doing that INO. What if they have a wound that's draining a lot of fluid? Or like, say, for instance, a burn patient. They're losing a lot of fluid through those burns. It's difficult to measure sometimes that extra fluid that they're losing. So going back to that daily weight is a good way to kind of keep in touch with their fluid balance. Okay. So we, as far as assessment for their fluid volume, we're going to monitor their cardiovascular changes. We've kind of already talked about that a little bit, monitoring blood pressure, monitoring pulses. Pulses, if they're weak and thready, that probably means there's maybe an underlying fluid deficit. If those pulses are very bounding, that could mean that there's a fluid volume excess. Looking at the jugular venous distension, we know that that's a very classic sign of right-sided heart failure. Okay, because there's extra fluid in our periphery. Measuring edema, do we have 1 + 2 + 3 + pinning edema? Again, that speaks to fluid volume excess. Also looking at BUN and creatinine. We'll talk more about it later, but BUN and creatinine, well, first of all, always think of kidneys when I think about what are my two blood levels that kind of show kidney function. It's BUN and creatinine. But also BUN specifically, if it's a little elevated, that sometimes means my patient's dehydrated. Okay, it doesn't necessarily mean that my patient has renal issues. It just means that the BUN, that blood urea nitrogen, is more concentrated because I'm dehydrated. And the same is true with your hematocrit. Remember, your hematocrit is just your concentration of red blood cells. And if the hematocrit's a little bit concentrated, a little bit high, that could mean that I have an underlying fluid volume deficit. I'm dehydrated. And once I get rehydrated, then you'll see that decrease back to normal range for my hematocrit and for my BUN. So just that slight elevation of BUN doesn't always mean kidney problems. Sometimes it's just a sign of dehydration. Okay, the same with your hematocrit. So just remember that. Let's see here. So we talked about that. Make sure you're reading through all of this. Respiratory care. Again, lung sounds are a very important way to measure fluid volume, especially fluid volume excess, especially if we're thinking pulmonary edema. So here, especially when we're giving blood, especially to somebody who's older, we want to make sure that while we're giving that blood, that we're first of all not giving it too quickly. It should be given slowly unless there's a true emergency. And that we're listening to lung sounds probably every 1 to 2 hours. And if we all of a sudden start picking up, they were clear, and now we're starting to notice crackles, that could mean that we're giving that fluid, we're starting to get a little bit of a fluid volume excess. And maybe because the patient's older, they're not handling it as well. Maybe there's an underlying heart failure going on. And so some of that fluid is being pushed out into the pulmonary vascular system and on into the actual, across the alveoli into the lungs. And so you want to be monitoring for crackles. There's a good picture there. Let me see if it's, yeah, of measuring skin turgor. That's very important, looking for tinting. That and it's very true. I know my husband one time was dehydrated and he was in the hospital because sometimes you don't, sometimes these things you don't really see that well, but he was truly dehydrated, and sure enough, when I pinched his skin on his dorsal surface of the hand, it stayed kind of in that tinting position, just like you see in this drawing here on C. So that is a sign of dehydration when you have skin tinting. Now, another place to look at that is over the kind of the skin, kind of over the sternal area. You can kind of pinch that skin, especially sometimes in older people, sometimes because of the loss of the collagen in the skin. Sometimes over the hand, you don't get as good of a picture of the tinting as you might over more of the sternal area in your older patients. So kind of keep that in mind. Of course, we know patient safety is an issue with fluid volume status. If we're again looking at fluid volume deficit, we're thinking possibly they have lower blood pressures related to fluid volume deficit. And so maybe they're okay when they're lying down, but when they all of a sudden stand up, they have orthostatic hypotension related to the decrease in the fluid volume within the vascular system, and they're going to possibly pass out on you because of the hypotension when they stand. So make sure you're looking at that. Skin care is very important when we're talking about fluid volume deficit or excess, especially excess. Sometimes edema can get so bad in people, especially when you're getting into the actually third spacing, not just second spacing, that you can have weeping of the skin, that literally the fluid weeps through the skin. And all of a sudden you notice that you think you're sweating, but it's really not sweat. It's serous fluid leaking out onto maybe the pillow that their arm is elevated on. So, and that, of course, is just one example of how skin integrity could be affected, okay? So, going on, we talk about a little bit about fluid therapy, and then we're going to start talking about sodium imbalances. So sodium, so we're talking about sodium. Serum sodium we know is what's the normal level? I think sometimes it's 142. Some books are a little bit different. I just kind of have in my head 135 to 145. Sodium balance is very important. It does play a role in extracellular volume and concentration. It's important for the generation of transmission of nerve impulses, important for muscle contractility and acid-base balance. So it is very important that we have a good balance of sodium. So when we have too much, it's called hypernatremia. Hypernatremia would be sodium levels then above 145. This can occur maybe because there's inadequate water intake or there's excess water loss. So maybe we're just not drinking because we're older and we don't have that thirst sensation. Or maybe we're NPO related to surgery. We're about to have surgery tomorrow. Or maybe we're NPO because we have pancreatitis, okay? Maybe we have excess water loss because we have nausea, vomiting, diarrhea for the last 5 days. Very rarely is it just strictly because of sodium gain, hypernatremia. There's usually an underlying fluid problem. So if we're dehydrated, we have not enough fluid, usually we see hypernatremia. When we have too much fluid on board, then we see hyponatremia. So kind of keep that in mind. Usually too much fluid on board is going to cause decreases the concentration of sodium. So decrease in our sodium level. When we're dehydrated, it's more concentrated. So we see hypernatremia. Okay? So make sure you understand that. Our primary protection, of course, is thirst. So hopefully if we're becoming hypernatremic, our body is going to say, ooh, we need to drink some more water, okay, to get more fluid on board, to dilute the sodium. Okay? I think that's just explaining. I think we've already kind of talked about this. So what are some signs that you might see in a patient who has hypernatremia? They should be thirsty, okay? Very possibly they can be lethargic, they could be very agitated, and it can lead to seizures and coma. They probably will have an impaired level of consciousness, and they probably will have symptoms of fluid volume deficit. So they may have tinting of the skin. They probably will not have edema, although they can. These are some of your nursing diagnoses related to hypernatremia, risk for injury, risk for fluid volume deficit, risk for electrolyte imbalance. To me, if you have hypernatremia, you actually just have electrolyte imbalance, not risk for. You can have seizures and coma leading to irreversible brain damage. So we want to try to treat the underlying cause. So we want to probably, the first thing is going to be to try to start an IV and start giving IV solutions of fluid, either isotonic or hypotonic fluids. We need to give them fluids, give them water, okay? If they can drink, we're going to encourage them to drink. And if they have to be MPO for whatever reason, we would definitely want to make sure we're giving IV fluids. So this is the person who has hypernatremia, that high sodium level. We want to dilute that sodium with free IV fluids and promote secretion with diuretics. So probably they're not going to be on normal saline. I would bet this person is going to be on at least, maybe if it's any kind of saline, half normal saline. Okay? So we need to give, or they could be on D5. They might be on something like dextrose 5%. We do need to monitor them carefully. We may want to, it doesn't exactly make sense, but we might want to give extra fluid and then give Lasix or give some type of diuretic to get rid of the extra fluid that we're giving them in order to hopefully just get the sodium back to where it should be. A lot of this kind of is where your physician comes into play in ordering the right mix of diuretics and fluid, etc. So we have a person here, 62-year-old female, admitted with confusion and lethargy related to, okay, now she has hyponatremia. Did we switch here? We were talking about hypernatremia, right? So now we're talking about hyponatremia. So hyponatremia, sometimes you have similar symptoms, but really the opposite is going on. So now the sodium level is too low. So the sodium level now is falling below 135, okay? Let's look at this real quick here. Hyponatremia, it's on page 280. It can result from the loss of sodium-containing fluids, water excess in relation to the amount of sodium, or a combination of both. Hyponatremia is associated with extracellular fluid hypoosmolarity from the excess water. So when you're thinking hyponatremia, usually we're thinking excess water. And believe it or not, hyponatremia is actually kind of hard to treat. A lot of times you're collecting fluid, you're not getting rid of the excess fluid, you're keeping the extra fluid. So it's not a matter of just saying, oh, they're hyponatremic, their sodium level is low, let's go ahead and just give them extra salt. That does not work. The problem is the extra fluid that the person has. So usually the very first treatment for hyponatremia is fluid restrictions. So make sure you know that. Usually the first line of treatment for hyponatremia, and usually that's related to excess water in the system, in the body, then you're going to actually be giving fluid restrictions. That's usually the first line of defense for hyponatremia. Because you can't just say, again, like as I said, let's give them extra salt. That doesn't necessarily work. The better way to start treating it initially is with giving fluid restrictions. Now, sometimes the doctor may order a hypertonic solution of maybe, I can't remember, a 3% sodium. Because remember, normal saline is isotonic. Normal saline is 0.9% sodium chloride. So one of your hypertonic solutions is a 3% sodium chloride. That's very hypertonic. You give it very slowly because it can damage the cells because of that osmosis that goes on. But sometimes that can be given as well. Okay, so let's look at hyponatremia. We're on page 280. Let's look at down at the bottom where it says nursing implementation. Managing hyponatremia from fluid loss includes replacing fluid using isotonic sodium-containing solutions. In mild hyponatremia caused by water excess, fluid restriction is often the only treatment. The aim of the restriction is 500 mLs less than the previous 24-hour urine output. Loop diuretics and another drug there can be given. If hyponatremia is acute or more serious, small amounts of hypertonic saline solution, which is normally the 3% sodium chloride, can restore the serum sodium level while the body is returning to a normal water balance. So kind of make sure you're reading through there. Of course, we need to be making sure that if we have problems with our sodium levels, that we're then monitoring the sodium levels very closely, okay? I have seen patients, your patients who are hyponatremic, often also, just like the hypernatremic, they come in, they're very, very confused. I know there was a while on skilled nursing, when I was working on skilled nursing, that all the patients that we were getting from the hospital side over onto the skilled nursing side, they were coming in with levels of sodium, serum sodium levels of 120, 122. They were worse than when they actually were admitted to the hospital as far as their sodium was concerned. And they were very, very confused. They ended up getting up without assistance because they didn't use the call light, and they ended up falling. So fall risk would be a very important risk for falls, would be a nursing diagnosis that you could use here. So just make sure you understand the difference between hypernatremia, hyponatremia. Hypernatremia, I'm thinking that they just don't have enough fluid, and we need to replace that fluid, and that usually then dilutes that sodium back to normal. But on both sides, they can be confused, okay, hyponatremia and hypernatremia. With hyponatremia, it's usually due to almost too much fluid, so our first step is going to be doing fluid restrictions. Okay? So I think I talked about that. We need to go on. So we're going to skip through that. Make sure you do read through your different types of your drugs that block vasopressin, your antidiuretic hormone. Make sure you kind of have a good understanding of those. And that's on the top there, I think, on page like 280. Okay. So now let's talk about the cation potassium and having too much or too little potassium in your serum. Okay. So we know that normally it is 3.5 to 5. We know that this is important because of our sodium potassium pump that we talked a little bit about earlier, and that's important in the regulation of our heartbeat. The sodium potassium pump is important in the regulation of our heartbeat. So that is why too much potassium or too little potassium can greatly affect our cardiac status, can affect our rhythm of the heart. So with that being said right there, what kind of monitoring system do you want on your patients when there's any kind of problems with potassium? Some type of heart monitor, okay? The basic kind in the hospital setting is the telemetry monitor. So you want to be watching your telemetry monitor at all times, okay? So they hopefully will be having a heart monitor on. So we know as far as just in general, you need to know where you can get, your sodium, your potassium, your fruits and vegetables, bananas and oranges. Salt substitutes, be careful. Now that this goes back to CHF, let me tell you real quickly about this. I had a patient who kept coming into the hospital. He had real bad congestive heart failure. We were giving good teachings about not adding salt to your food, trying to use other sources for seasonings, etc. And he kept coming in, and he came in with high potassium levels. He would have potassium levels of 6.2, 5.9, 7.0. We were really worried about his cardiac status, right? Because of that. Well, then finally one day I walked in the room, and he had on there this big thing that said no salt. So it was a seasoning that he got. Well, what is no salt? It's potassium. So you have to be careful about telling them about the different types of replacement, sodium replacements that they can use. They really should be using your natural seasonings like, I don't know, fresh basil or oregano. They really should be avoiding the no salt because it's actually not, instead of made out of sodium chloride, it is made out of potassium chloride. He was using that too much because he was shaking that on all his food. And that's where he was getting his extra potassium in. Have to be careful with renal patients. Renal patients, because their kidneys aren't functioning, they're retaining potassium. So they have to have diets that are very low in potassium. So they should not be eating bananas. They should not be eating oranges. If they're going to eat fruits, it needs to be fruits that are low in potassium. Strawberries are relatively low. Your berries are relatively low in potassium. And we'll talk more about that when we get to the renal chapter, but just kind of keep that in mind. People who have underlying renal disease, especially renal failure, need to avoid foods high in potassium. Again, your foods high in potassium include bananas and oranges, potatoes, okay? So again, your salt substitutes sometimes are high in potassium. So definitely a dialysis patient would not want to have the no salt brand in their house because it's just pure potassium that you're pouring on your food, okay? You got to look at the medications that you're giving. Look at the IV fluids that you're giving. Remember that lactated ringers does have a small amount of potassium in that fluid mix. So just be aware of what fluids are hanging. If all of a sudden you get back, you're monitoring your patient and you work in that morning and you get the lab results back and their potassium is 5.9 and they have hanging D5W with 20 of K, you may want to call the doctor immediately and get that discontinued. So be aware of what IV fluids you're giving. Potassium is in part mainly regulated by your kidneys. High serum potassium can be caused by impaired renal excretion. It can be caused by a shift from the intracellular fluid to extracellular fluid from massive intake of potassium. It is most common in renal failure. Again, sometimes you see it in rhabdomyolysis. Sometimes you see it when there's some type of, for whatever reason, muscle destruction within the body. Again, like maybe your patient lying on the floor for 12 hours, struggling to get up, and they were lying on that hard concrete floor. You'll see muscle destruction. And one of the signs of that is seeing that high potassium level, okay? What are you going to see with hyperkalemia? You may see cramping leg pain, weakened or paralyzed skeletal muscles, abdominal cramping or diarrhea, and cardiac dysrhythmias. And you also see this basically when you have, to a degree, especially the leg pain and the cardiac dysrhythmias, you see that when you have a low potassium as well. It's a little bit different in what you see, but you do see that. With hyperkalemia, so we're talking about hyperkalemia. It could be underlying renal disease. This is when their potassium is above 5, okay? The first thing that you'll see U waves. Actually, those U waves are going to start getting more and more prevalent as the potassium gets higher and higher. As you're developing higher and higher potassium, you're going to end up getting tall peaked T waves and a widened QRS. And I know probably you don't know what that means right now, so kind of just when we get into the cardiac system, we'll talk more about this at that point. You can end up, if the potassium gets too high, you can end up basically, you just end up flatlining your patient. That is why you never give, so if they have low potassium, which we'll talk about more about in a minute, but when you do give any kind of IV potassium replacement, it's always done very slowly, over at least an hour. You never push potassium IV. And I think, did you learn that last year? Was that spoken before? Did everybody know that? You would never just take a vial of potassium. Oh, their potassium's 2.6. You know, the doctor said to give them 10 milliequivalents. I'm going to pull up in a vial and give it over 2 minutes. You're going to kill your patient. Y'all know that? Y'all got that? You don't kill your patient. Okay? This is actually part of when you are, when somebody isn't receiving a lethal injection. That is the main thing that they're receiving in that lethal injection. Normally they're giving a barbiturate or some a pain medication, and then it's followed to kind of put them to sleep, and then it's followed by a IV push of potassium to stop the heart. That's how lethal injection is done. So don't do lethal injection, okay? So with that being said, and I'll maybe mention it again, normally the best way to give it is 10 milliequivalents in a bolus over about an hour. No faster than 10 milliequivalents over 1 hour. So a lot of times you'll have 10 milliequivalents in 50 cc's of saline, and you want to hang that over an hour. So your rate would be 50 cc's an hour. Does that make sense? So it's never, and in fact, a long time ago when I first started in nursing, we kept potassium on the floor in vials. And the little vial tab said on there, must be diluted. That was our warning to say, oh yeah, we can't just go give this to the patient. We got to put this in our normal saline. Now this was only in the ICU setting, but when I worked in ICU a long time ago, we mixed our own bags. So if we needed normal saline with 20 of K, then we would go get the vial and put it into the 1,000 liters of, or 1,000 liters, 1,000 cc's, milliliters of normal saline, and then hang it. But I guess at some point a mistake was made, a lethal mistake. So now you never see potassium in vials anywhere on the floor. It is only kept in the pharmacy. Okay, at least I know that's true at our hospital, and I think that's pretty much true anywhere. So just to avoid that possible error that could exist, because you never want to give it IV bolus over a push. You would want to give it in a mixture of saline over 10 milliequivalents over at least 1 hour. And you would want to be monitoring, probably if you can, their cardiac status. They should be on telemetry when you're doing that. Okay. Now, let's go back to our actual problem at hand, though. We're having hyperkalemia here. We already have too much potassium. What are some ways we can get rid of that potassium? Let me think. Does it say here? Yeah, we can give diuretics. Especially we could give Lasix to try to get rid of. We're going to be getting rid of some fluid along with it, but hopefully getting rid of our extra potassium. We can give what we call K-Exolate. This is a medication. It's a liquid medication. It can be given by mouth. It can also be given as an enema. Same medication. You're either giving it by mouth or as an enema. Now, unfortunately, you have a side effect of having severe diarrhea, loose stools with this drug, but it is a very quick way to get your potassium level down. You can do this. In emergency situations, you can give IV insulin. Because the way insulin works, we already talked about how it does take sugar into the cell, but it does also drive potassium into the cell. So remember, our potassium that we're worried about is out here on the outside of the cell. Insulin is going to bring it into the cell, thus decreasing your serum level. So giving IV insulin, now what's the side effect of giving IV insulin? Low blood sugar. You don't want to have a low blood sugar now, oh my goodness. So along with your IV insulin, you're going to also then be giving a bolus of probably dextrose 50% with that. So just keep that in mind. And that is normally only done when you're really getting kind of high, probably into the 6 to 7 range of potassium. Probably for just a potassium of 5.5, you're not going to do that. Okay, but when you're getting to the high range, what if you have a dialysis patient? Maybe they missed 2 of their dialysis treatments, and now they come into ER with chest pain, and we find out that they have a potassium of 7.2. We could go ahead and do maybe these initial treatments of giving them maybe the insulin and the dextrose, but we need to get them to dialysis as quickly as possible, because in their dialysis treatment then that potassium will be pulled off. Okay, so those are some different ways to decrease potassium levels. Okay. Oh, another one, I always forget about sodium bicarb. Sodium bicarb can also be given IV push to help decrease potassium. Okay, so and calcium gluconate. Probably what y'all would be giving more, especially as newer nurses in the setting, would probably be giving either the IV Lasix and or giving that K-Exolate. And again, like I said, unfortunately then, and you can give it, as I said, by enema or by mouth. It's like a syrupy type thing, and it is gonna cause diarrhea, loose stools. So you have to deal with that side effect. But so we had this little patient here. He was confused and lethargic. He does have a history of hypertension, type 2 diabetes. He doubled his Lasix for the last 2 weeks because he felt puffy. So he is going to maybe possibly end up with hypokalemia. So that's when we have low sodium. Our sodium now is below 3.5. So here we have increased loss of sodium via the kidneys or the GI tract. In this case, sounds like it was his kidneys because of the extra Lasix. It could be a dietary deficiency. You don't see that too much. It could be related to magnesium deficiencies, metabolic alkalosis. So he has a potassium of 2.8 and his hematocrit is 56%. So our potassium is low, but the hematocrit is what? So sometimes what does a high hematocrit mean? The dehydration. Probably if we did a BUN, his BUN would probably be a little bit elevated right now as well. So even though he's felt puffy, he's been taking this extra Lasix. He's now caused himself to have fluid volume depletion, and he's lost the extra potassium along with the Lasix and the IV fluid. So that's probably the problems that's going on. It says here the hematocrit level is secondary to your extracellular fluid loss. So we're most worried about the cardiac status, the rhythms he might be having. He probably is having muscle cramping and weakness, weakness of the respiratory muscles, decreased GI motility, impaired regulation of arterial blood flow, and hyperglycemia possibly. So now what you see here, and again, I know that you don't know much about cardiac rhythms yet, or some of you do not, but what you are at risk for when your potassium is too low is having PVCs, premature ventricular contractions, and going into VTAC or VFib. And those are lethal dysrhythmias. You have usually no pulse, especially when you have VFib, and often with VTAC, ventricular tachycardia. It's really easier to talk about this, and I will later in cardiac, so I'm not going to dwell on it now, but just remember, too much potassium, if you're hyperkalemic, you're worried about basically tall peaks, T waves, and as it worsens, you end up going basically flatline. When you have low potassium, below 3.5, you're worried about starting to have frequent PVCs, which are premature ventricular contractions, which can then lead to ventricular tachycardia or ventricular fibrillation. Either way you're going, it's leading to death. So you've got to correct your potassium balances, okay, or imbalances. So with him, he has very poor skin turgor. That's probably showing us that he is dehydrated. He has leg cramps. His heart rate's 135 and irregular. He's breathing kind of rapidly at 126. I'm sorry, 26 breaths per minute. Blood pressure's a little bit low. So we're thinking here, again, I don't quite get these. It's not risk for electrolyte imbalance. He has actual electrolyte imbalance. Risk for activity intolerance, risk for injury, potential complication, definitely is dysrhythmias. So he should be on what type of monitor? Some type of telemetry monitor, right? So we wanted to correct his fluid replacement. So we're giving him 0.45 normal saline. I'm actually, half normal saline, which is 0.45 sodium chloride. And we are giving the potassium replacements. So how much will we administer? Well, we'll administer what the doctor says. What is the doctor going to say? So again, probably depending on how low he is, he was 2.8. He probably is going to, the doctor will probably start by ordering some potassium via IV as a IV piggyback, not a push. 10 milliequivalents and say 50 cc's over at least 1 hour. He may order 2 or 3 of those. And then probably he's going to also put the patient on PO potassium, maybe 10 milliequivalents TID or something like that. Okay.
How
So
quick does it raise the potassium when you get potassium? Like, does it take a long time or does it just depend on the person?
I think it depends on the person, but I can't, I'm not sure exactly how much increases it, how much, it depends. But normally, I bet if we gave him even just 2 bags of 10 milliequivalents of potassium and 50 cc's, it would probably the next morning when they, or he might, the doctor, if it's just a 2.8 potassium, he may not even, or he or she might not even order the labs until the next morning. And I think you would see an definite improvement to near normal ranges, if not on the low side of normal by then. So, okay. So we talked about teaching, like teaching in this case, he probably should not have decided on his own to take his Lasix, double it up, just because he was puffy. He should have gone to the doctor to talk about that. Maybe the doctor would have increased his Lasix, but maybe would have also put him on a potassium supplement if he wasn't already on one. Okay, so I would say the most important part is of teaching would be to make sure he's not diagnosing and prescribing his own medications or increasing his own medications, and that he does know maybe how to eat foods that are higher in potassium. So if you really are on a lot of Lasix, you probably should be eating a banana each day or an orange each day, eating foods that do have higher potassium levels. Okay, so now we're getting into calcium. I know we're going slowly. Calcium is important for the formation of teeth and bones. It's important in blood clotting, transmission of nerve impulses, and it's very important in those last 3, transmission of nerve impulses, and our myocardial contractions, and our muscle contractions. So when we have a problem with either having hypercalcemia or hypocalcemia, that's where we're going to actually see our problems, especially in those last 3 things. Okay. Where do we get food? We get food from the foods that we eat, or calcium. Where do we get calcium? We get calcium from the foods we eat. We do need vitamin D to absorb calcium from those foods. So we have to be getting, so that's a lot of times why, especially in women, as they get kind of past the age, I think, of kind of in that premenopausal years, sometimes they need to have extra intake of calcium as far as a supplement. And a lot of times you also are taking vitamin D along with that calcium supplement to make sure that the body does absorb the calcium. Okay. There are different types of calcium biologically. Ionized calcium is biologically active. We're not going to get into that right now. Just keep in mind changes in the pH and the serum albumin does affect the level of calcium. We'll talk, that's a long discussion. We'll talk about that a different day. It's imbalanced in part by the parathyroid hormone and calcitonin. Okay, those are hormones. Parathyroid hormone does come from the parathyroid gland. Where's the parathyroid gland found? On the thyroid. So we're going to talk here in a minute about what if we had to have a patient having thyroid surgery. The doctor needs to make sure that, or try to, as he's removing the thyroid, he has to leave some of the tissue there so that the parathyroid glands remain. What if accidentally the parathyroid glands are removed? All of a sudden, you're going to have a very, very bad imbalance of your calcium. We'll talk more about that in just a minute, but it's very important to keep that in mind. So our high levels of serum calcium can be caused by hyperparathyroidism. It can be caused by malignancy or prolonged immobilization. So prolonged immobilization. So how do we get calcium into our bones. Impact. When we walk, when we run, when we exercise, but we're bearing weight on our bones. That is how we are getting calcium into the bone. So when your patient's immobilized, your patient's not walking anymore, okay? There's no impact on those bones. The calcium is not going to stay in the bones. So that's why sometimes our blood level of calcium gets high, is because of those prolonged times of immobilization. So that's why the walking is such a good exercise, not just for the body because it's good for the cardiovascular system, it's also good for our bones because the impact is what gets calcium into our bones, okay? So anyway, that's then how prolonged mobilization causes that increase in calcium, because calcium is leaving our bones, going back into the blood. Malignancy, there's just so many things going on in the body with cancer and with malignant cancer, but just keep in mind, hypercalcemia is a problem with that. We'll talk more about that later too. There's so many disease processes that are going on, but just remember, malignancy can cause increased calcium in the blood. What are your signs of too much calcium? Hypercalcemia. And make sure, and that is one, for whatever reason, I don't keep it in my head as well, the range. You do need to know the normal range for calcium. So, and there's not like a black and white little box that just gives you the ranges in this chapter. I don't know why they did that. It's kind of mean, but make sure you know your normal range of calcium. I'm going to go on because of time's sake. So the patient can be lethargic, weak, possibly even end up in a stupor or coma. You're going to see depressed reflexes, decreased memory, confusion, personality changes, psychoses. We might see anorexia, nausea, vomiting, bone pain, fractures, nephrolithiasis. That means that you're making kidney stones in the kidneys, okay? Because, again, we have all this extra calcium in the blood, okay? You might see polyuria and dehydration. Those you're also, again, at risk for injury, at risk for you have electrolyte imbalance. You are, again, at risk for dysrhythmias because calcium, though not quite as important as potassium in our heart contraction, calcium is also important in contraction in general. So we can maybe give a loop diuretic, because with the loop diuretic, if it's ordered by the physician, we also have some excretion of calcium within the kidneys. We can hydrate the patient with an isotonic saline. We want to put them on a low calcium diet. We want to try to get them to start walking if they can and they haven't been. Somehow mobilize them. We can give synthetic calcitonin. So that's going to put the calcium back into the bone. Calcitonin puts the calcium back into the bone. And also by the bisphosphonates. Okay, what about low calcium? Low calcium, serum calcium, can be caused by a decrease in PTH. It can be seen in acute pancreatitis, multiple blood transfusions, alkalosis, increased calcium loss. So here, this is where it is very important for you to know this. What might you see? You're going to see, because basically now there's not enough calcium to really make your muscles work well. You can see a positive Trousseau's or Chevesque sign, which I'll show you in just a minute. A laryngeal stridor, dysphagia, tingling around the mouth or the extremities, and cardiac dysrhythmias. So make sure you understand the signs of hypocalcemia. Make sure you understand this. And remember, I said a time where you might all of a sudden develop hypocalcemia is after a thyroid surgery. So maybe the patient has too much thyroid hormone, or maybe there's a tumor within the thyroid, and the surgeon needs to go in and remove the patient's thyroid. The surgeon still needs to leave some of the tissue where the parathyroid gland is. and sometimes, believe it or not, because, when you look at a picture of the parathyroid gland, it's just all nice and pretty, and you see the little, parathyroid glands are on the posterior surface of the thyroid gland, and those 4 little spots. It just seems like it's all nice and pretty, right? Because it's a picture. And in real life, when you're doing the surgery, that's very, very difficult tissue to discern, So you got to watch after the surgery's done. We have to watch for these signs of hypocalcemia. We got to make sure that hopefully the doctor did not remove that tissue, and the patient's not going to have a problem with this. So if you're taking care of your patient, it's been a few hours after the surgery, they start saying, gosh, I'm having this tingling around my mouth. Or if you notice some other things, it might mean, uh-oh, there's a problem. We need to let the surgeon know immediately so that we can intervene. So this is test for hypocalcemia. 2 things. The Chevesque sign is when you kind of stimulate, kind of just with physical stimulus, just kind of touching the cheekbone up high. And if there's a twitching at the mouth, that's the Chevesque sign. That's positive. That means probably you have a low calcium. The other one is if you put a blood pressure cuff on the arm and you start blowing it up. If you have this kind of twitching and movement, more of a spasm, I guess you could say, carpal spasm in the hand, that is also a sign of low calcium, hypocalcemia. And I thought, oh, there. Let's see if we can go here real quick.
Okay, go ahead and squeeze your hand for us. Good, squeeze like that. Good, and then back out. All right, it won't increase. But you can relax your hand down.
You can just relax and keep it like this, please.
So he has a blood pressure cuff on the hand now, or the arm.
Just let us know what you're feeling as we're doing this.
It's trembling right now. I'm going to sleep.
Okay.
Now it's starting to curl.
What do you mean? What do you mean trembling?
It's starting going like this. It's shaking.
Can you control your hand?
No.
Okay.
It's going like this by itself.
Try to straighten your fingers up.
I can't.
You can't do it.
I can't.
All right. What do you feel right now?
I want to go like this and flatten them
You're
back
trying
out.
to.
Yeah, but I can't. This goes way in here like this.
Yeah.
And will not move.
Up.
Now look, it's crunching even more.
And you're not doing that.
I'm not doing that.
Okay.
Matter of fact, I want to pull it back out. See see the other one is doing it too.
Right, and this is what happened earlier to you.
That's what happened over here.
Okay.
It went just like that.
I'm going to release the pressure now.
Oh, see, it's pulling it more down.
Let us know how you feel as it.
There. See?
Now, what's it feel like?
Fine.
Tell
it's
it
not fine, but it's sleep.
I see. Now move.
Okay, so that's the Trousseau sign. So a way to test for hypocalcemia. The other one is the Chevesque sign. So let me notice that he has a lot of tattoos, and it was difficult to start an IV in his arm. So now let's try this. Let's try the. We didn't try that one, did we? This is, I think, both actually. I didn't show us much of this Chevesque sign. This is the Trousseau sign again. And see how that hand's kind of starting to spasm? I want to do this. Let's do that one real quick. This is the Chevesque sign. Okay. Okay, so, and it looked like he had just had some type of thyroid surgery. So you got to monitor that in your patients, especially after thyroid type surgery. You want to treat the cause, you can give oral or IV calcium supplements. You don't want to give it IM. You can have them rebreathe into a bag, and I think that has to do with the carbon dioxide levels. I'm not exactly sure how that works. You treat pain and anxiety to prevent hyperventilation-induced respiratory alkalosis. Okay, it all has to do with respiratory alkalosis and stuff. Okay, so make sure you understand, so make sure you understand high and low sodium, high and low potassium, high and low calcium. Make sure you understand those different signs that you look for hypocalcemia. Okay. go ahead and read about hyperphosphatemia. We need to start skipping over some stuff because of time. So I think I'm going to skip over that, although that is important as well. I'm going to skip to make sure that you are understanding about magnesium. Let's look at that. We're on page 286, magnesium imbalances. It does mention that magnesium, I'm on page 286 for the new edition. Magnesium is the second most abundant intracellular cation. It does play an important role in essential cellular processes. Again, well, it's important, it says, for, I'll let you read all that. It is important also in heart rhythms. There's one heart rhythm, it's called torsades de pointes. It is a specific type of ventricular dysrhythmia. It's a type of ventricular tachycardia. And often when your patient is in that, their magnesium level is low, and we need to give magnesium. So just kind of make sure you try to remember that. Let's see here. So a high serum magnesium is caused by increased intake or ingestion of products containing magnesium, especially when there's renal insufficiency or failure. And it can be caused by excess intravenous magnesium administration. So you have to watch for this. What type of patient do we like to give magnesium to for other underlying problems? For your patients who are pregnant who have PIH, pregnancy-induced hypertension, preeclampsia, oftentimes we are giving them magnesium. And y'all learned a little bit about that last year, right? But you do then have to watch for signs of hypermagnesium levels. So make sure you read through that on how to do that. Okay. So as far as hypermagnesium anemia is concerned, prevention is first. Restrict magnesium intake in high-risk patients. If you do need to give an emergency treatment for high magnesium levels, you're going to give IV calcium chloride or IV calcium gluconate. And I think you all learned that last year, again, in your patients who have, maybe they're on that magnesium drip because they're preeclamptic or have PIH, that you do, if you all of a sudden notice problems and there are high levels of magnesium, that you can give the IV calcium or IV gluconate to reverse that. You can give fluids and IV Lasix to promote urinary excretion, and you can even do dialysis if necessary. Low magnesium can be caused by prolonged fasting or starvation. It can be seen in chronic alcoholism. It could be seen if you have maybe some nausea, vomiting, and diarrhea, maybe with diuretics. Your problems there would be confusion, hyperactive deep tendon reflexes, muscle cramps, tremors, seizures, cardiac dysrhythmias, and you may also see along with that low calcium and low potassium. Okay, you just need to give replacements. IV fluids, just because of time and because of the confusion, we're going to skip or go through here very briefly. Just remember again, hypotonic solutions, basically you're giving more water than the actual concentration of the fluid. So in your patient who is dehydrated and we need to give them fluid, often we're going to give hypotonic solutions so that we're giving them more water, giving them fluid. And it can be used also as a maintenance fluid. Isotonic expands only the extracellular fluid. There's no net loss or gain from the ICF. It's an ideal way to replace extracellular volume deficit. So we had a little bit of maybe some blood loss, but not a whole lot. We can give just the normal saline. In hypertonic, it's going to expand and raise the osmolarity of the extracellular fluid. It requires frequent monitoring of blood pressure, lung sounds, and serum sodium. Sometimes if you're giving a hypertonic solution, you're going to be, because of the hypertonicity of the fluid, you're pulling fluid out of the tissue. So that's why you have to really watch then for signs of increasing extracellular fluid volume. So monitoring lung sounds, because you don't want them to all of a sudden, again, if they're underlying heart failure, You can end up getting extra fluid volume within the vascular system because of pulling it out of the tissue. And then you can end up in congestive heart failure again. So anyway, you want to monitor blood pressure, lung sounds, and serum sodium levels. D5W is considered isotonic. It also does provide a little bit of calories, not much, okay, but it can prevent ketosis associated with starvation. D5W, free water moves into the intracellular fluid, increases renal solute, used to replace water losses and treat hypernatremia. But it doesn't provide actual electrolytes because it's just sugar water. The rest of these, make sure you understand that normal saline is isotonic. It's the preferred fluid for immediate response. So that's why we so often hang normal saline, which is 0.9% sodium chloride. No free water, no calories, no additional electrolytes. It's often given when we're hanging blood products or given along with the blood product. And it's very compatible with most of your medications. You all know that. Okay. Lactated ringers is an isotonic solution. It is very similar to our plasma, except that it contains no magnesium, but it does contain sodium, potassium, calcium. Okay. If you happen to have lactic acidosis, you're probably not going to want to have that hanging. Also, if you have hyperkalemia, you're not going to want to have that hanging because it does have some potassium in it. I would encourage you, if you can, to look at the, look it up on, your book or Google it and just see exactly what does lactated ringers have in it and what concentration of those electrolytes are in there. D5.5 normal saline is considered hypertonic. It is a very common maintenance fluid. It can replace fluid loss. And oftentimes we will add potassium in there if we need to add potassium. A lot of times you'll see D5.5 with 20 of K hanging. So D10 is hypertonic. It provides free water but no electrolytes. We want to limit the dextrose concentration. Limit of dextrose concentration may be infused peripherally. You got to be careful as you're getting into more concentrated levels of IV fluids. Often then they cannot be hung through a peripheral line. You would need a central line. Okay. I think we're almost done. I'm going to go ahead and I'll let you read about plasma expanders. Blood is considered one. Head of starch. I don't see it given very much anymore. Sometimes in the OR settings, I think we give head of starch if maybe we're having quite a bit of blood loss and we need to give a fluid volume expander. It helps pull fluid out of the this tissue space into the vascular system. So all of those are kind of like that. Okay, just because of time's sake, we're going to go ahead and go on. I think what I'm going to have to do is we're going to talk about ABGs. I'm going to have to just make a video on ABGs. So I'll do that. I am going to go ahead and flip us over now to not ABGs, but we're going to go over to our hematology chapter and hematology assessment. So, and we'll skip through a lot of this, but let's go. So that is over on what chapter is it? In your new book, it is chapter 30. Hematology problem. Actually, no, it's 29. Assessment of the hematologic system is in chapter 29. That starts on page 586, 587 in your new books. I believe for the older edition, that is chapter 30. Oh, 31? Assessment of the hematologic problems. Yeah, you had chapter 31 in the old book would probably be your actual problems. This is just assessment of the hematologic system. We'll talk more about the problems. I believe that lecture is going to be next week. Lots of terms you need to know. Make sure you know those terms. Whenever your book has the key terms, make sure you know those terms. Also, before you start your chapter, kind of read through the learning outcomes. That'll kind of tell you what you need to be learning while you read that chapter. We know in general, we've already talked about it, but where do our blood cells come from? They are made in our bone marrow. Okay, and the formation of blood cells is called hematopoiesis. And this occurs within the blood cells, that term hematopoiesis. And if you're being more specific, when you say erythropoiesis, that is specifically the formation of red blood cells. And we've talked about it briefly. We'll talk about it more detail later, but when your kidneys sense low levels of red blood cells, your kidneys secrete the hormone erythropoietin. That chemical hormone travels to the bone marrow, and then your bone marrow will, in response, make more red blood cells. In your kidney patients or renal patients who have renal failure, often that mechanism is no longer working. So oftentimes you see low levels of red blood cells. And of course, what do we look at? What level do we really look at when we're looking at red blood cells? Our H and H, hemoglobin, hematocrit. They're going to have a low hemoglobin, low hematocrit. So often we give epogen, which is artificial erythropoietin. And again, that stimulates in the bone marrow to make red blood cells. Okay. So anyway, just in general, we know that everything's made blood cell wise. It starts out in our bone marrow. So we have our blood. Let me see here. I am on the right chapter, right? Because this is, I think the first part of the chapter is just talking about the formation of blood. So just keep in mind, you have different components of your blood. You have plasma. So let's read that real quick. Blood is a type of connective tissue. We know that it is very important for transportation, regulation, and protection. There's two major components, plasma and blood cells. In the adult weighing between 150 and 180 pounds, the volume of blood is usually between 4.7 and 5.5 liters, or 5 to 6 quarts. So approximately 55% of the blood is plasma. Okay, plasma is composed primarily of water, but it does contain proteins, electrolytes, gases, and nutrients, and waste. Now, what is the difference between plasma and serum? The term serum refers to plasma minus its clotting factors. So plasma does have clotting factors. So when we give plasma to a patient, we're providing them clotting factors along with serum, okay? Because sometimes we give FFP, right? Have you heard the term FFP? Fresh frozen plasma to patients, and maybe it's because they have some things going on and they have, for whatever reason, low clotting factors at that time. So when we're giving FFP, fresh frozen plasma, we're giving them clotting factors. We also can give them platelets, and platelets are very specifically part of a type of red blood or a type of blood cell that does help promote clotting. But platelets are not the same as the clotting factors within plasma. So just keep that in mind. So your blood cells, about 45% of the blood is composed of actual blood cells. And three types of blood cells are erythrocytes, which are the red blood cells, the leukocytes, which are the white blood cells, and the thrombocytes. So make sure you understand those terms. Your erythrocyte, red blood cell. Leukocyte is a very general type of white blood cell. You have very specific types of white blood cells, but in general, they're all referred to as leukocytes. And then you have your thrombocytes, which are platelets. And platelets are actually fragments of cells, fragments of a very, very big cell. Platelets are, of course, important in part of our clotting processes and making sure that we don't bleed to death. Leukocytes are important in the immunological function of our body. And red blood cells are very important in carrying oxygen, okay? When we look at blood cells, red blood cells in particular, to look at how many red blood cells, we don't necessarily, when we're looking at it, so when we're looking at lab values for our blood cells, we're going to be looking at hematology, and we're going to normally be looking at a CBC, a complete blood count. And you can have different types of CBCs. You can have a CBC with a differential. The differential then is specifically looking at what kind of different white blood cells do we have. You can do a manual differential where you're actually looking at them under the microscope, the lab person is, and literally counting the different types of white blood cells. So make sure you just a CBC is just a complete blood count in general. You can have a CBC with a differential where with the white blood cells they're looking at different types of white blood cells. And then you can have a CBC with a manual differential where they're doing that differential in a very specific way by looking at it under the microscope. So make sure you have kind of an understanding in general of that. When we're looking at it, we want to know, gosh, how many red blood cells does my patient have? For whatever reason, we don't really look at the actual red blood cell count. We look at two different numbers. We look at the hemoglobin and the hematocrit. The hemoglobin is kind of the weight of the hemoglobin within the red blood cell. The hematocrit is the actual percentage of red blood cells in all of the blood volume. So basically, if you take a little tube of blood, you put it in a centrifuge and you spin it down, the red blood cells are the heaviest, so they're going to go to the bottom of that tube. And then right on top of the red blood cells are going to be a very fine line of your white blood cells. There's, in comparison, you have many more red blood cells than you do white blood cells. And you can see a good picture of that on page 589. I don't know where I'm at on my slides. My slides are kind of different. Well, anyway, look at that page on page 589. It shows you your whole blood percentage by volume. So plasma is 55%. Your formed elements are 45%. And then if you look at that, most of those are your erythrocytes. And then you have your leukocytes kind of on top of that and your platelets on top of that. So when you're looking at your erythrocytes, red blood cells, that's simply the percentage, and it's in a percent. So if you say that you have 36% hematocrit, that means that 36% of your blood are red blood cells. And there's kind of just a rule of thumb that if you take your hemoglobin, multiply it by 3, you should approximately have the number for your hematocrit. So say if your hemoglobin is 10, then roughly your hematocrit should be about 30%. And if you, so try that out and as you go through your next series of clinicals and look at some different patients and look at their H&H, their hemoglobin hematocrit, and see if that kind of holds true. So in general, we know, I think for a woman that there's a chart somewhere, but 11.7 to I think like 38 is normal for a woman for a hematocrit. It's a little bit higher for men. But in general, what do we consider low? So, I'm sorry, on what? Below 35? Gosh, yeah. I look at the hemoglobin, honestly, as far as my first number that I look at to see, are they going to need some blood? Are we going to need to give them packed red blood cells? So when the hemoglobin drops below 10, normally if they're right at a hemoglobin of 10, maybe it's been, they've had a knee surgery. They were, say, maybe at a hemoglobin of 13 when they started, but their baseline before surgery. They've dropped down to a 10. Probably as long as they're not exhibiting any signs of any problems, their blood pressure is still okay. When they get up, they're not dizzy. The doctor's not going to consider giving them blood. The next day, their hemoglobin drops down to maybe a 9. So their hematocrit's probably around a 27%. They're starting to, they say, boy, when I get up, I get a little bit dizzy. Their blood pressure is now dropping and their heart rate, it was 70 at rest and now it's 90 at rest. Their heart rate increases up to 120 when they're walking in the halls. Then very possibly the doctor is going to say, I think they need some blood, and may order 1 or 2 units of packed red blood cells. So when they're in the 9 range, it really depends upon the signs or symptoms the patient may or may not be having. Again, if they're at a 9 and they have, again, no real signs or symptoms of blood loss, probably the doctor's not going to order it. When it gets below the 9 range into the 8 range, oh, they're probably going to end up getting packed red blood cells. When you see a hemoglobin in the range of 7, you probably should be saying, oh, dang, that's really low. I need to do something. Now, with all that being said, I have seen patients walk into the emergency room saying, I don't really feel good. They have a hemoglobin of 4. That means their hematocrit is around 12%. That means they have barely any red blood cells in their body. but it happened over a very long period of time. Maybe they have a slow blood loss, maybe due to a colon cancer, and they're losing blood in the colon and they just didn't realize it, and it happened over a long period of time. Their body's used to it. So they're still not doing well. They definitely need blood. We got to intervene. But they didn't actually have to come into the emergency room until it got that low because it happened over a slow period of time. Versus if somebody comes in with a gunshot wound, they're going to be feeling the effects then of that low hemoglobin and hematocrit very quickly. But keep this in mind very quickly. So if somebody comes in with a gunshot wound, if we draw their blood right at that very minute, the gunshot wound took place, when the gunshot was like 10 minutes ago, they are losing a lot of blood. But when you draw their blood right then, is their H&H going to be low? No, because nothing has happened to change the volume yet. But now they're oh my goodness, they're losing a lot of blood. We're going to start IV fluids. When we draw blood 12 hours from now, are we going to see a decrease in the H&H? Yes, because now we gave them some saline, maybe some fluid expanders to get that volume back up, but we weren't necessarily replacing with red blood cells immediately. So you are going to then see the drop in the hemoglobin and hematocrit. And you often see this, I often see this in our patients, especially after knee surgeries. We do the knee surgery, they did have a lot of blood loss, and they're still losing a little bit of blood through that wound. The very first day, there is a little bit of a drop in their H&H, but it's not that bad. They went from a 12 down to a 9.9. The second day rolls around, second day post-op, now they're at a 9 hemoglobin. Third day post-op, now they're at 8.2. So a lot of times you don't get blood in your orthopedic surgeries until about the second to third day post-op because you don't really see that true drop in the H&H until then. So kind of just keep that in mind. No, I'm not really going by that. In fact, I must going to, because I don't think this slide presentation is that good. Yeah, well, honestly, it's not. So I'm just going to finish talking to you, and I'll go ahead. Not that you need to see me, but I'll go ahead and just put it on me, because I'm just going to go by the book right now. Okay, so let's look at your book. We're in the book. So we talked a little bit about hemoglobin, understand hematocrit, understand how they are related, and they both are giving you a picture of your red blood cells, also known as your erythrocytes. And those are so important because they are carrying our oxygen. Very important. Make sure you know the normal numbers for those. Now let's talk a little bit about leukocytes. We're on the bottom of page 589. Our leukocytes are our white blood cells. They appear white when separated from the blood. Okay, I'm on the bottom of page 589. Like red blood cells, leukocytes originate from stem cells within the bone marrow, but they eventually reside in the thymus or the secondary lymphoid tissues, such as the spleen, the lymph nodes, and the Peyer's patches. There are different types of leukocytes, and they have different functions. And there's a good, on that page on 589, it kind of tells you there are different types of leukocytes. You have neutrophils, lymphocytes, monocytes, eosinophils, and basophils. So again, we're not going to, we talked a little bit more about that in detail when we talked a little bit about the immune system. Probably as we go through different disease processes, we'll be bringing up that topic again. But remember, you have different types of white blood cells, also known as leukocytes. And the majority of those are your neutrophils. Okay, so kind of keep that in mind. Breaking down your different types of white blood cells, you have granulocytes. That is a type of white blood cell. And neutrophils are a granulocyte specifically. Okay, there's something that you need to understand about, and that's about what we call segs and bands. So I'm looking at page 589. So how white blood cells are released into the body. They are released normally as a segmented neutrophil. We call that a seg. So a mature neutrophil is called a segmented neutrophil or a seg, or a pulmonary. Anyway, just remember it's called a seg, because the nucleus is segmented into 2 to 5 lobes connected by strands. Okay, so our body is nice and normal. We have no infection. So we have some neutrophils floating around. But in these neutrophils, they had a chance to mature. They're all nice and grown up. They look like segments. So they're segs. These neutrophils are called segs. Now I have this horrible infection in my body, and my body is really trying to fight it, right? So now I'm calling up all my neutrophils to attack this. And now I'm running out of my mature ones. So I'm going to have to go and get my immature ones, my little immature bands. They're called bands. And it says that although band cells are sometimes found in the peripheral circulation of normal people and are capable of phagocytosis, the mature neutrophil is much more effective. An increase in neutrophils in the blood is a common diagnostic indicator of infection and tissue injury. It doesn't explain it as well as I would like to say, but it's just that when you have an increase in bands, that means that your body probably has an underlying infection because you're having to release the immature neutrophils to fight the infection. You've run out of just the segs, the mature ones, and you're having to call upon the bands. So now if you think about it, I wish I had a picture here. We call that a shift to the left. Have you all heard that term before, shift to the left? So think about it, on my left-hand side are my little baby neutrophils, they're bands. And as they grow up, they're shifting to the right, right? Here are my mature ones on the right side. But now remember, and right now, all I see in my blood, because I don't need that many neutrophils, I only see the grown-up segs. But when an infection comes, I'm now going to have to shift over and call all of my little white blood cells into play. So I'm shifting over to the left and getting my bands involved in well. So when we say a shift to the left, that means that we're seeing both bands and segs in the neutrophil count. And that it probably is meaning we have some type of underlying infection. Does that make sense? So understand, and I would encourage you, because I don't think I explained it that well, but look up and see what a shift to the left means. If you want to do a Google video or whatever, you need to understand what a shift to the left means. Okay? So we're going on in the book. Make sure you're reading through. We talked a little bit about eosinophils in the immune system. Eosinophils only account for 0 to 4% of all white blood cells. Their primary function is to engulf antigen-antibody complexes formed during an allergic response. An elevated level of eosinophils is also seen in some neoplastic disorders, in various skin diseases and connective tissue disorders, and also in parasitic infections. A lot of you missed that question on the test. And I think I did cover it in lecture last time, so I'm emphasizing it again today. When you have an increase in eosinophils, remember that little phrase I said? It can be due to worms, wheezes, or weird diseases. So when you have an allergic type reaction, you might have an increase in eosinophils. If you have a parasitic infection, you may see an increase in eosinophils. Or sometimes certain different types of skin diseases, you see that increase in eosinophils, okay? And it's just a very particular type of a white blood cell, okay? So understand that. Read through the rest of those. I'm not going to kind of go into the details, and I'm not going to go into the clotting mechanism because it's so complicated. But do look at that picture there on 591. Look at how complicated the clotting mechanism is. This is called a clotting cascade. I do want you to know that platelets take a major role in your clotting cascade. So when you have low platelets, you're going to have a problem then with clotting. Okay, so make sure you understand that. Let's keep on going. I'll let you read through that. Let me see. Let's go ahead and skip over. I think we kind of know enough just about the basics of that system. Let's talk quickly about the assessment of the hematologic system. So if you're doing an assessment on your patient in general, of course, you're going to want to know about past health history. Determine if they've had previous problems with anemia, bleeding disorders, blood diseases, such as leukemia. Document other related medical conditions. You want to know their meds. That's very important, okay? It starts there on the bottom of page 593. A complete medical history, a prescription, and over-the-counter drugs. It's very important to know. Inquire about the use of vitamins, herbal products, etc. There are certain herbs that can interfere with clotting. And that should be on a box on, where is it? It's in chapter 37 on page 820. Also know that your chemotherapy drugs, you need to know about any kind of chemotherapy type drugs that they may have taken in the past, any antiretroviral drugs that they may be on, because that's going to affect definitely the white blood cells. There are certain drugs that interfere with clotting. Can y'all think of some drugs that interfere with clotting? Coumadin. Oh, definitely Coumadin. If they're on that specifically for clotting purposes, Coumadin or Wayfarin. And I can say that one. Salicylates. That is a drug that does interfere. So would you want your patient to be taking that type of drug, salicylates, right before surgery? Definitely not. Okay. So assessing that. There are certain types of herbs. Let's look at that real quick. Page 820. Let me go over to 820. There's a table on 820. It talks about different drugs. And here it says anticoagulant therapy. I was looking for here at the bottom. I'm sorry. That is a good table for y'all to know about, which we'll talk more about probably next week. But making sure that you do know your anticoagulant drugs. That includes Coumadin. It is a vitamin K antagonist. Of course, heparin is a thrombin inhibitor. There are different types of heparin. We give low molecular weight heparins. That includes Lovenox and Fragmin. Those are given subcutaneously. And I've talked to some of my students already about it, but one of the things that you have to watch with low molecular weight heparins, really any heparin, is in some patients you can develop heparin-induced thrombocytopenia. When you say the word penia, thrombocytopenia, that means you're decreasing your number of platelets, or thrombocytes. Thrombocytes are platelets. Thrombocytopenia. So when you're giving heparin or low molecular weight heparin, such as Lovenox or Fragmin, you've got to look at your platelet number. And if you're starting to see a big decrease day to day in your platelet numbers, you may need to end up stopping the heparin. So you need to notify your doctor of those decreases. If you're going from 120,000 down to 90,000, that's significant. Or even 120,000 down to 110, the next day then you're at 90. Usually I think it's when you're around 90,000 that you're going to end up holding the heparin or the Fragmin, whatever has been ordered, and the doctor may stop that drug. So just when you get a chance, look up low molecular weight, heparin-induced thrombocytopenia. Let's look at the bottom real quick there on that page 820. It just says the following herbs and dietary supplements can affect blood clotting. Bilberry, black cohosh, chamomile, chondroitin sulfate, feverfew, garlic, ginger, ginkgo biloba, ginseng, melatonin even. So you would need to know these if you're doing an assessment, especially if you're focusing your assessment on blood. So make sure you're asking the right questions. It talks a lot about that. And then we need to look at the patient. Let's look at our physical assessment because we're running out of time here. So one of the things I would look at is, first of all, just the color of this patient. And are they pale? And where can you look at for paleness besides just their general color? You can look at the general color. Sometimes you need to know a baseline because some people kind of appear pale, but maybe that is a natural color for them. But look at, or what if you have darker skin people? Sometimes it's a little bit more difficult to assess, are they pale or not pale? And of course, if we know if they're pale, we're thinking they must probably have a low level of red blood cells, right? When we're thinking pale, we're thinking low level of red blood cells. You can look at the conjunctiva, first of all, because it's your conjunctiva, no matter what color your skin is, your conjunctiva should be very nice and pink. If it looks pale, probably they are anemic. You can look at your nail beds. Your nail beds should be overall nice and pink. If they are kind of pale in color, that probably then means that the patient's anemic. If they happen to have an ostomy of some sort, a colostomy, you can look at the stoma color. The stoma normally is nice, that beefy red color. If it's kind of pale in color, they're probably anemic. So those are just some different, the mucous membranes, the tongue, the mouth. Look at that. If it appears pale in color, they're probably anemic. So those are just some places to assess for that. You need to be kind of, and we don't really teach you a lot about doing the lymph node assessments. That's really more at the nurse practitioner type level, but it does kind of go into a little bit of the lymph node assessment, and that can tell you about your white blood cells in general. There's a really good table there on page 597 talking about pallor of the skin or nail beds or flushing. Sometimes there are certain diseases where you actually have too many red blood cells, which we'll talk about next week. So if you see that bright redness to the skin, that could be maybe that the red blood cell count is too high. Okay. If you're looking at jaundice, now there you're thinking more of a liver disease, but often you see that in the skin or the mucous membranes. Now, if your mucous membranes or your nail beds are appearing very blue, that could be, of course, a sign of cyanosis. Sometimes that is related to our hemoglobin and hematocrit because we don't have enough oxygen carrying capacity with the red blood cells. Another one to think about is petechiae. What is petechiae? It says it there. Pinpoint, non-raised, perfectly round areas greater than 2 millimeters. They're purple, dark red, or brown. And that can be due to some kind of bleeding disorder. Maybe it's related to a decrease in platelets or clotting factors. And because of that, you're seeing these small hemorrhages into the skin. Those can be seen either as the purpura or the petechiae, or even the bruising. If you just have bruising, that can be telling you that my platelets, or maybe somewhere within my clotting factors, there's a problem. So looking at the skin is a very good way of looking then indirectly at the blood to see if there's any abnormalities. So make sure you're reading through that table there on page 597. Definitely make sure you understand what petechiae are, what bruising is. Another word for bruising, ecchymosis. Okay, make sure you're looking at that. And then the book goes into a little bit there on page 599. It starts talking about your CBC. So again, as we said, the CBC is a complete blood count. So you're looking at the white blood cells and red blood cells. We said already that the red blood cells, we're going to be normally focusing on the hemoglobin and the hematocrit. Make sure that you understand that both of those. Make sure you understand normal ranges for both of those. We've already talked about that. White blood cells, overall, your normal range for that is around 4,000 to 11,000. We know that if you have too many white blood cells, probably it's related to some type of infection. Okay. If you have not enough white blood cells, that term is referred to as leukopenia. Make sure you know that term. You see leukopenia oftentimes with bone marrow depression. Now, the bone marrow depression could be from maybe they have cancer and they're receiving chemotherapy treatments. Because remember, chemotherapy is going to affect all of the blood, all of the body's cells, not just the cancer cells. And remember, one of the cells in your body that are that it's replicating very quickly are your bone marrow cells and your blood cells. So that's why chemotherapy does have a direct effect on your bone marrow and your blood cells. So that's why you often see decreased numbers of your blood cells when you're getting chemo. So leukopenia might be caused by chemotherapy treatments. It could be caused by radiation. It could be caused by a type of leukemia. It could be caused by HIV. So leukopenia is when your count drops to less than 4,000. And they're going to be, of course, we know because that our white blood cells fight disease, we're now going to be at risk for infection. Now, what about the opposite? If you have white blood cells and you have very high amounts of white blood cells, they're probably your body is having some type of serious infection going on. Okay? So a lot of times when you're septic patients, we do white blood cell count, and sure enough, your white blood cells count is very high, so they are septic due to some type of underlying infection. And also it explains briefly there the shift to the left on page 600, so make sure you're reading about that. When your body is not making enough neutrophils in general, the term is called neutropenia, and that is when you have I think the neutrophil count is less than 1,000. Severe neutropenia with an ANC of less than 500. This is determined by the multiplying the total white blood cell count by the percentage of neutrophils. You don't necessarily need to know that. Just know that neutropenia in general is a type of leukopenia. And again, we're very worried then about the patient being susceptible for infections. So we would want to take all of the precautions necessary to make sure that they are not introduced to any kind of new type of bacteria that could cause them to be very sick. So you would want to read your precautions on that, which I think Mrs. Walker talked about when she did her chapter on cancer. Make sure you understand the platelet count normally is 150,000 to 400,000. When you have low count of platelets, it's below 100,000, thrombocytopenia, and you can have bleeding can occur. It says spontaneous hemorrhage is possible once the count falls really low, above 10,000. And I have seen patients who have severe thrombocytopenia for some underlying reason. They come in with a platelet count of 1 or 2. I have, you will see that in your nursing career, especially if you're working on the floor. Obviously, they are immediately given lots and lots of platelets. Oftentimes, those platelets don't last very long. So keep in mind, severe spontaneous hemorrhage can occur once platelets counts fall below 10,000. So those patients need to be very, very, very safe. We definitely don't want them to fall down. We don't want them to be using a razor. We want them to be using a very soft bristled brush. Make sure you're reading all kinds of precautions that you need to know for your patients if they have thrombocytopenia. Okay. Let me just, I'm going to have to put something up on Moodle about some more things that I just haven't covered enough. So let me just look real quickly here. I think I did cover quite a bit that I needed to. I will put some more things out on Moodle in the next, over the weekend. I do need you to know this, and this is kind of switching, to a different part of the chapter very quickly. But understand what a central line is, what a peripheral IV is, and what a PICC line is, kind of the differences, okay? So a PICC line, that's P-I-C-C, I know y'all probably already know this, but it's peripherally inserted central catheter. So even though you see it in the arm, it is actually a very, very, very long catheter, normally put in by somebody who is trained to do that. Normally it is a nurse who's specially trained. That catheter is very long, and it does go up to it enters usually to the right atrium. So it is considered a central catheter, but it was inserted peripherally. Those are long-lasting catheters because it is inserted peripherally, but then it goes into the right atrium. It is considered a central catheter. So we can give different things through it that we can't give through a peripheral line. One good example would be TPN, total parenteral nutrition. Total parenteral nutrition usually consists of what? Amino acids, high concentrations of sugar, because that's the nutrition, right, for that patient. Usually it's when it's a patient's NPO, maybe after a really serious GI surgery. They need good nutrition. You can't give TPN through a peripheral line because it's too concentrated, and giving that concentration of solution into just a little bitty vein, it's not good for the patient. We want to give it into a very big vein, so it's going into the vein, the subclavian vein, right as it's entering the heart. So it's mixed very well with the blood because it's given into the right atrium. Does that make sense? So that's the advantage of having, one of the advantages of having a PICC is because you can give things like that you normally would not give in a peripheral line. Another advantage, okay, so the advantage then of a peripherally inserted line versus just a central line, the doctors will put in a central line sometimes. Now they actually go just right up here in the subclavian space, usually into the subclavian vein, and they put in a catheter. It goes to the same place. It goes into the right atrium, but it's put in very centrally. Because we're putting it in right in this area, in the chest area, what are some things that could go wrong? Well, we could accidentally, as the doctor is putting it in, and it does happen. It's a risk of the procedure. It's not because the doctor, he didn't know what he's doing. It is a risk of the procedure. We might accidentally puncture the lung. So after the insertion of especially a central line, you're going to want to really watch your patient closely, watch their respiratory status, etc. If all of a sudden they're saying, oh man, I'm not breathing very well, it's really hard to kind of catch my breath, you want to go ahead and make sure you're listening to lung sounds. If you notice maybe decreased lung sounds on one side, you want to call the physician. Normally, we'll immediately order a chest x-ray. The physician will then look to see if there's a pneumothorax. The pneumothorax would be a consequence of accidentally puncturing the lung. It does happen. So in that case, then the doctor would need to then put in a chest tube to relieve the pneumothorax and then allow it to heal before removing the chest tube. So that is just a complication, a possible complication. Also, a pulmonary embolus could be a complication of putting a central line in. That could also be a complication really with a peripherally inserted line. You just have less of a chance of that happening with a peripherally inserted line. So make sure that you understand that. Real quickly, so the term pancytopenia, pan means all around. If you're thinking of Latin root words, pan means all around. So pancytopenia means that you have low blood counts in your area, your thrombocytes, your leukocytes, and your red blood cells, or your erythrocytes. Often in those cases, and sometimes in other cases as well, how do you diagnose what's going on? You may need to do a bone marrow biopsy. So normally the physician will, so we actually have to go in and biopsy, get out some of that bone marrow to test it. Normally that is done in the hip region, in the pelvic region. Okay, removing some of the bone marrow from the pelvis itself. It's just kind of done with a puncture, along like a long, hard, I guess, puncture type needle. So of course we're worried about afterwards, especially if they already have decreased number of thrombocytes, we're worried about bleeding. So you do want to monitor for bleeding afterwards. Just use some common sense with that. If they are bleeding or they're at a risk for bleeding, would you want them to lie on the actual site? That would actually be a good thing because the body then would be making just a natural compression of the site. So hopefully that would help prevent bleeding. So oftentimes the patient might be asked to lie, if it's on the right side, then they may be asked to lie down then on the right side for about an hour afterwards, just to exert that extra pressure to prevent any kind of bleeding after a bone marrow biopsy. So, okay, I know I ran a few minutes over, but I am done. ABGs, we do need to talk about ABGs. I'll try to go ahead and learn how to do a Zoom video, and I'll put some type of video. If it's not me, I'll put somebody else out there. I'm sure there's some good ABG, but we do need to understand ABG, so I'll try to put that out there. We'll talk more about ABGs as well when we get into the respiratory system, so don't think that it's forgotten. Okay, any questions, Altus or Lawton? I'm sorry, I'm in Elk City. My brain's dead.
We don't have any.
Did you still want to meet, Polly?
I sent you a message. How about we meet like at 1:30?
Okay.
Okay.
That's fine. Okay, thanks y'all.